Belly Shoulder Podcast. With us today, I have a very, very special guest, as usual, Dr. Reza. How do you say your last name?
Jazayeri.
Jazayeri.
But everyone calls me Jazz.
Everybody calls me Jazz.
Yeah.
Dr. Jazayeri. So he's a orthopedic surgeon. He practices sports medicine surgery in Los Angeles. He went to Cal State Northridge for undergrad, studied mechanical engineering.
Yeah, I started out mechanical engineering, and then I come to the double major. Ended up, I was interested in like skeletal metabolism, so did a kinesiology, and it was a dual major. Actually.
Physio, kinesio.
Yep. It was physiology with an emphasis on skeletal metabolism.
So you learned a lot about basic science.
Yeah, I kind of geeked out on that stuff early, man.
In college.
Yeah.
And then Einstein. So you must have done well in school, and then you went to Einstein.
I did pretty good, fortunately. Yeah.
New York.
Albert Einstein, New York. Yep.
Medical school.
Med school. Yeah.
And then NYU, HJD.
Yeah, that's when it was HJD. Yep,
disease.
Hospital Joint Joint Disease, and
for orthopedic
surgery.
Orthopedic surgery. A lot of trauma there.
A lot of everything, man. We were very grateful to have the New York experience. You know, it was a great city to live and really an awesome place to do training. Zuckerman, Dr. Zuckerman is just an incredible mentor, and he's been a key part of many aspects of a lot of people's lives. So
research and
just a friend, just a good leader, someone
teaching.
who I've learned a lot. You know, I work with residents now, and I try to, take a piece of what I learned from him.
Hey, he's learned. He's been awarded multiple lifetime achievement awards, I think.
All day.
So multiple
awards. He deserves all of them, really.
Yeah, he's amazing. So you did orthopedic surgery there.
Yep.
And then so New York for a while, and then you came back to L.A.
Yeah, came back to L.A.
At Curlin Job for training.
Very fortunate to be at Curlin Job for my fellowship. It was awesome.
1 year, right?
I was very fortunate. That year was the Lakers beat the Celtics. It was an awesome year. I learned a lot. It was a great year.
Okay, so and was Rafi there?
Rafi was a few years ahead of me.
He was before you.
Yeah, Rafi was before me. Yep.
Yeah, yep. Rafi Mirzayan.
Yep.
And then you stayed in LA after that, right?
Yeah, I thought I was going to go back to New York, but LA, the weather's good and family's here. So
are you from LA? From that area?
Yeah, yeah. I grew up in the Valley area.
Valley.
Yep.
So Northridge wasn't far from home then.
No.
So you did all that, and then you've been practicing orthopedic surgery
almost 15 years now.
15.
Yep.
How's that going for you?
I love it, man. Some people, get burnt out or whatever. I really still really love what I do.
Yeah.
It's
you like being a surgeon.
We get to help people.
You don't really know what it's like to be a surgeon until you become a surgeon, though. You can see it, but to really know, to live the life of a surgeon, I would argue you got to live that life a bit to feel what it's like to live as a surgeon, and to know if you really like being a surgeon.
Yeah.
Do you like being a surgeon?
I love it.
Yeah, me too.
Yeah. Yeah.
It's so cool.
It's great.
It's really great.
We get to really be impactful in people's lives.
Definitely. There's a lot of different ways we can help people. We can help them through knowledge, through teaching, through being a good doctor, also being a good surgeon, right? So there's all those things, and then when you put them all together, you can be a really good person that helps another person, right? In a way that is pretty unique.
100%.
Yeah.
I think being a technician, a surgeon is
got to be a good technician.
A part of it
as a surgeon.
That's how I kind of got into it. I like the fact that I could use my hands and fix things. But then dealing with people and and choosing the patient population that you like. Initially I thought I was going to go into spine maybe because my uncle was a spine surgeon. He motivated me. He was one of the guys who, when I wasn't sure what I was going to do, I went to see him in New York, and he was putting in pedicle screws with drills, and I was working with like cars and stuff, and I was like, wow, this is incredible.
Putting screws right in the pedicles.
Yeah.
Trying to get those angles right.
Drills.
Yeah. Dropping screws. Oh, I got to go get that one. How do I get that out of the car? While you're back there?
And I was like, this
probably
guy.
Useful technique, right?
Yeah. I was like, this guy's the mechanic for the human body.
Right.
And that was it.
Because the screws look like screws, right? Like the screws in mechanic shop. Like the ones that are holding the plates together. The same thing in the OR.
When I used to play around with cars and work on the cars, it's using your hands, and then you're looking for performance out of a car, but you translate that into the human body.
That was your uncle, you said?
Yeah, my uncle was a neurosurgeon in New York, and so
How did you have experience with him? Did you shadow him? Or
Yeah. So I was probably, at that point, I was probably like 18, 19. And my mom was like, you can't keep, being in the garage and racing cars. And,
you can't,
because
she was like, you're not
she was
allowed.
worried.
Why, are you going to get hurt, or she didn't like you racing?
Yeah. Yeah. That's what I would say.
Racing.
Yeah. I was,
was it the racing or the working on cars that she didn't like?
I think the racing,
what kind of racing were you doing at the time?
At that time, I was working with a Honda Motorsports. There was a company called Good, and they made camshafts for Hondas, and they needed someone who.
Can you describe what a camshaft is? I know a little bit about cars, but I know what they look like, and I know they're deep inside the engine. But Teslas don't have them, right? Do they have camshafts? Well, we know what a cam is, right? A cam is like a circle with an apex. So right. It has some kind of mechanical advantage. Yeah. So the cam is like along this long rod, and then it rotates. But
it rotates.
What does that do? It like flips things or something?
So what it does is it controls the intake and outtake of air and combustion.
Okay. In the carburetor.
It basically creates the valve speed and the duration for how far it's open.
So it's frequency.
It's frequency, its duration, is how far it's open, and
open and close, right?
Yes.
Like the distance.
Yes.
So this is all very precise.
Very precise, and to be able to increase performance, most cars that have camshafts, they're designed for fuel efficiency. But for performance, you want to change the camshaft to have different specs, where you want to improve essentially how the car's breathing. By improving the intake and the duration the valves are open.
How much oxygen it's getting into the chamber, right?
For fuel performance. So Good made camshafts, and that's what they did. So that's what I got into it. And then they needed someone to test the cars. So at that point, I was very young, and I was willing to almost do it for free.
You were testing their cars.
Yeah. So that's what it was. Yeah.
Wow.
So I would help put the camshafts in. And then I would figure out,
better do a good job if you're going to be.
I fucked it up a bunch of times before I finally learned. Yeah, it's my first time I actually tried it. I had it 180 degrees backwards, and the car wouldn't turn on. It took me a while to figure it out. But this is how we get better, right? Even with surgery,
it was closing when it should be open.
Yeah, it was 180
right?
degrees backwards.
You learn that in physics. If it's off, if the frequency waves are off by this much, everything is completely messed up to either zero or it cancels.
Well,
right?
I think that's just
it cancels if it's that way, but then if it's one more, then it's opposite. Yeah. That's how I explain it, and I think that's why I got a B- in physics.
but the reality in life is we learn from.
But those concepts, you learn those concepts, and it carries you through to a lot of different things.
Absolutely,
and it gets your brain working right.
Totally, I think for me the concept of working on cars, and then being in athletics, sports, the combination of those two will kind of help my mindset. Getting through medical school, getting through orthopedic surgical residency, and even my practice now. You build on your previous experiences.
What gave you the drive to basically study and learn all of that stuff at such a young age? I mean, that's a lot of dedication and work and time in the garage when you could have.
Oh my God, my mom was like, "Get out of the garage!"
And your mom's yelling at you anyways.
Totally.
And you still wanted to do it.
It would be.
What got you to? What do you think that was? That pushed you to learn like such a detail, because some people just don't like that stuff at all. Do you think it was just something you were really into? You enjoyed it? Or was it something that was just, this is necessary to get?
No, I was into it, man. I was into it. I wanted to figure things out. I was always interested in kind of figuring things out. And
you liked math, I'm sure.
I liked figuring things out, and so, and I liked kind of performance. And at that time when I was a kid, my cousins were into race cars, and so I wanted to learn. And I told my dad, "Hey, Dad, I want to get into this." And he goes, "Yeah, sure, no problem." And so I thought that meant what my cousins, who my uncles had money, that meant take your car, drop it off at the mechanic shop, and then they're going to do it for you.
Tune it up, you get it ready to race.
Tune it up, and then you come back, 4 or 5 days later, and you got a cool, car
with stickers on it.
That was not the story. My dad's like, "Yeah, you could do it." I was like, "Well, when are you going to take me to the mechanic shop?" And he's like, no. I said, "You could do it." And he's like, "I meant you can do it."
Not like one could do it.
Yeah.
Like as in you.
I was like, "What do you mean,
being
me?"
The person that will do it.
And then I realized what that meant. So then I just went to the Honda store, like the mechanic store, and I bought the book. I still remember.
What kind of car?
It was a Honda Civic.
Yeah.
It was a Honda.
It was a front wheel drive.
Front wheel drive. But I remember doing my homework, and then after my homework,
what year?
That's when I was swimming.
What year?
It was that year was
what year was the Honda?
Oh, that was like in 1990. Yeah,
90. They're still pretty light back then, right? Or what were those cars?
Actually,
like
the lightest one was the CRX.
They're pretty like built to like race, and you could be pretty hard on them. They're good racing cars if you tune them right.
Yeah,
right?
I mean, that was back in the day, right?
Yeah.
So it was a lot of fun. But
a little car a long time ago.
But I remember even then it was like do my homework, and then I was into swimming and water polo, swim, and then come home, and then on top of my homework, start reading the Honda manual so I can learn how to take the car apart. And that was my first experience in taking the car apart.
You have to take it apart to be able to.
Dude, I was like, I had all the things laid out,
Yeah.
like pre-op planning. And then I remember the next day,
Did you mess anything up?
Oh yeah. And so I remember one day my dad came home. He's like, "What the F are you doing?" And I was like, "I'm doing, it took me 3 months to get the,
You say, "Dad, I got to make a mess to clean up a mess."
So you know what he did? He was pissed because
I'll
he
put it
forgot he
back
told
together.
me.
Just give me some time.
He went inside the house. I'm like, oh man, he's gonna be pissed.
Yeah.
I was like 16, 17.
Right.
He had just bought me this car, and I took it apart. And then I was like, I'm dead. So he comes back in his jeans, and he's like, let me help you. So we try to figure it out. And the next day, I'm having breakfast, and I'm like, so Dad, can you drop me off at school? He's like, no, I bought you a car. I'm like, but my car's not working. You know that. He goes, that's your problem. So he dropped me off at the bus stop.
He's a tough guy, man.
So, but I love him, man. You can, but then that forced me
to learn
really
life lessons, right?
learn it.
Yeah.
And fast forward, I learned, made some mistakes, but then really got good at it. And then I started making, more kind of connections through that. I started doing other people's cars.
Yeah.
And that
because then they knew you could, put together cars that worked and didn't fall apart.
Then,
right?
Yeah, and then I raced them. So then my friends would see, hey, this has performance.
You raced them
because I was working with Good,
and you were working on them and racing.
Working
them.
on them. So that
gives you credibility.
So that's how I was working on,
credibility on the streets.
Kind of on the streets. We go down to Terminal Island in down south in San Pedro. There was a racetrack down there. We'd race the cars.
Fast and the Furious.
A little bit, but but that was that. You're 16, 17. That's what you do.
Here and there. Street racing is illegal, folks.
Now I have an electric
Only
car
on
and none of that.
Yeah, right. I mean, the electric stuff is great.
But my point is, at that point in different. Life, it changes your mindset. You asked me what it is, right? But that was the time my mom was like, go to New York, go hang out with your uncle. You can't just keep doing this. And then that's when I saw him doing spine surgery, and I was like, this is badass. And that was kind of flipped. And that's it, man. Really, that, it just seemed very seamless after that.
How into cars were you at the time?
I mean, enough that what I was, I told you what I was doing.
It was the thing you were doing.
I'd be in the garage on my Saturdays for 2-3 hours sometimes, and it was fun, right? Because you have the adrenaline. You have the adrenaline of like putting this together, and then, we'd bet money on it. And so it was like pride, and, you're 16,
you're making your way.
Yeah.
Right?
You know how, like, when you're 16,
yourself.
17, everyone has
doing
a thing,
something cool.
Right? And so that was kind of the thing at that time.
Very cool. I mean, I was in a go-kart racing a bit, motorcycles, dirt bikes, but it was always, it never got to competition for racing, and so to race is just, it's like, there's only one winner, like Ricky Bobby says, if you're not first, you're last. It's true. You're not first, right? So like the winner is really the guy, you score points, and then there's winners and there's a pole, and obviously, but there's that one winner, and that's why racing is so cool. It's the fastest guy that can get around the track, and you're that guy.
Yeah. My biggest win was I beat my cousin's Mustang, and he was like,
What kind of Mustang?
He actually had a, he had a 1994, and he had a souped up Mustang.
Yeah.
And it was 8-cylinder, 4-cylinder.
Yeah.
V8. Yeah.
I
think I still have it on video. My cousin hates to see
my
it.
dad has a 2013,
was a Colby,
I think, Shelby GT.
Shelby, yeah.
Those are cars.
Yes.
It's got a lot of power.
Yeah.
But
so anyway,
racing's super cool. I still like going fast. I love going fast. I like going fast on motorcycles.
You do?
Oh yeah.
Oh man.
I love it.
Yeah.
I just love it. I'm always going to go fast. I love going fast.
Despite all the stuff that we see and we fix.
Oh yeah.
Oh my God. Well, because you
I know a lot of good trauma surgeons. They're great. They've already operated on me. They've helped me in a lot of different ways. But no, I have a lot of good friends. So I believe I can't live life in a bubble. I do jujitsu and I do martial arts, and right. I mean, it's like I do competition for that. I've had injuries, and you have to try to assess risk. And so I think like optimizing people, when we talk about nutrition, that's why I want to have you on. I want to have you on the show really to talk about optimization.
Yeah.
So what we're talking about here is not ways that people can be okay. You know, we are talking about that, of course, but we're talking about ways that if you just get through it, you know, there's always a certain percentage of risk in surgery and every treatment that you get in medicine and any type of intervention that we do. It's never just you get a benefit. There's always some risk. You have to come in, you have to spend some of your time, you have to talk to us. We have to talk about pain. We have to talk about maybe that there's going to be side effects, right? Maybe that there is going to be some other way that we can avoid those issues. With surgery, we're causing trauma. We're literally harming the body in a minimal way, hopefully, to get better results from that harm. So we balance that harm that we cause, you know, up front. Sometimes people get harmed worse than the work that we do to get them better results. So the incisions that we make are, you know, we have to cut through the skin, we have to separate tissue to get to the bone. We do orthopedic surgery. So what that means is we were working on the limbs. We're working on the hands, the wrists, the joints, the shoulders, the neck, all the places that move. So we really have to know what's going on. We really have to understand our anatomy just from here, from the ground up is anatomy. So we have to understand all the structures that we're working around. So that's just to be competent, right? So we're not talking about that. We're talking about ways that we can optimize results. So as surgeons, we look at different ways that are, sometimes we pick our patients and sometimes we don't. Sometimes trauma happens and then you got to go see your doctor and he's a trauma surgeon and he says, you need surgery and I need to fix this. If you don't fix it, your leg's going to be crooked. You're not going to walk anymore. So you listen to your doctor's advice, right? And so you don't select that patient. But you know, if there's certain things that need to be optimized for that patient, say their blood sugar is 300 when they come in, do you think cutting them open is going to be a good idea? It's not going to heal. It's way too high. So that number is too high to heal. So it wouldn't be a good idea to do surgery. Even if grandma comes in with a hip fracture, you know, her blood pressure is only 65 and she's not able to stand up without being lightheaded. Okay, we got to optimize her heart and make sure she doesn't need some kind of heart procedure, some kind of interventional procedure of her heart, and maybe make sure all of her labs are optimized. Within a day, we can do those things and optimize that patient so that we don't cause harm and kill grandma, right? That's a real thing.
Yeah, we have a 30% mortality.
30% mortality with hip fractures. Just by walking through the door, you have a mortality risk just from having the hip fracture. So that person is already at a very high risk of death, right? So we should agree that if we want to keep grandma alive, you know, we should do everything that we can to you know, optimize her health before we try to, you know, fix her problems. And that's a real discussion that we have to have, and we have to be real about those things. By the way,
we just talked about this at the recent annual meeting of the Academy. That percentage of 30% mortality has not significantly changed in the last 30 years. And, you know, this is why we're now discussing, despite all this technology,
awareness.
What else can we do? What else can we modify in our patients, you know, to then make them the best candidates, right? Obviously, when you have an elective procedure, you have a little more time, but in the trauma setting,
what can we do?
They come in already.
Go ahead. There's something we can do, right?
Sure. Oh, absolutely. And so, you know, I think
you can't do everything, especially a trauma patient comes in. But you can do something. We can agree on that. You can help optimize and get them better off. Okay, maybe it's not, we're not going to wait 5 days for her to get the procedure she needs, but we're going to try to do something that will get her stabilized or optimized. And then she gets her surgery so she has the best chances of coming out of that in a good state, right?
100%. You know, one of the things that has evolved in my head as I've been doing this is before, you know, I went into this almost like the mechanic, like the technician. You know, and I think as surgeons, for the most part,
that's the fun stuff.
It's fun, and we kind of told ourselves, this is our job. I'm a surgeon, I'm a technician, and I'm here to fix things. And I would say, for the most part, we're very good technicians, right? And we all have different set of skills, but we're pretty good, and we can probably fix anything. However, that's not necessarily going to lead to healing.
Exactly.
And there's a difference now between being a good technician and being someone who is actually going to have a meaningful healing impact. Right. And this is where now,
for example, before you get to that, you fix the fracture. It looks perfect on the X-ray, and then they come out of the surgery, and then they get a blood clot and then don't make it out, right?
Right.
Or they have some complication from that, right?
Or it doesn't heal.
Or it doesn't heal.
Non-union.
They have
whatever,
a non-union,
you
right?
know,
So just
infection.
that, it looks perfect, and then maybe they don't make it through.
You know, what do we always say in orthopedics? It's like nothing ruins your results like follow-up.
Follow-up.
Right.
Mhm.
And
We
so
think we're great until we see otherwise.
I can't tell you the number of cases, you know, as a resident, you know, and even when I first started out, high-fiving, boom, this looks great.
You gotta be careful with that.
This reconstruction looks awesome. 4 months later, something's wrong.
You learn from
Right.
it.
You learn. And so that's for me, you know,
It
where
humbles
I've
you
shifted.
too. It humbles you.
It humbles you. And I think,
And it should humble you.
and I think,
It
you know,
humbled me. My cases that come back when I think I've been high-fiving and I see, you know, ways that can be better or mistakes that are fixable or potentially preventable. Some things you fix on your own from other people, and then you see your mistakes and you say, oh yeah, that's right.
my
But
practice,
that's okay. You just
yeah,
got to be aware of it.
my practice has ended up being kind of the disaster practice where I take on a lot of revisions,
Sure.
redos, and
Of what? Shoulder,
shoulders and ACLs,
total shoulders.
total shoulders, rotator cuffs, and ACLs.
You do revision, basically revision sports.
I
and
do
revision,
I do a lot of revision
arthroplasty.
sports.
Do you do revision hip and knee?
No,
Like joints?
I'm the only joint I do is shoulder arthroplasty, but I like shoulder from beginning to end.
So sports mostly in
Sports, and then the reconstructive knee, you know, cartilage osteotomies.
shoulder. Elbow?
Some elbow reconstruction, but I don't do joints. I don't. Total elbows are not.
We have a similar practice then.
Yeah.
Very similar.
Yeah,
Other
so-
than I do probably more elbow and more complex elbow.
Yeah.
And then I don't do any knee.
I don't. Yeah. So I think for me, my knee practice is almost 50% of my practice.
Yeah.
I do multi legs and a lot of that. And so because of seeing a lot of failures, and the first surgeon oftentimes did a good job. It wasn't the technique. Sometimes it is, but sometimes it's not. And then so when
Absolutely.
I look, right. And
There's
so when I
more
look
factors
back
than just
and I say, you know what am I going to do differently now? Right. This is where thinking outside the box and saying, you know, what are the other variables outside of what we do in the operating room that make an impact, you know? And so this is where the whole thing with nutrition started to come up.
How did you think about that? Like, what was it that got you thinking about that? Was it a particular case, or was it like what do you think put that idea in
You know,
your head?
it's interesting you brought up like the whole car thing and performance and cams, you know, because to me in the back of my mind, the fuel that you put in the car mattered, right? And I can tell you from the time, you know, I was swimming, the way we ate made a direct impact on our performance, right? And even when even during residency, we had this thing called the 300 Club where you try to bench 300 pounds, right? It was like, you know, sounds kind of like the classic orthopedic thing.
Yeah, the Bros Club.
Yeah.
Ortho Bros.
Yeah. And so my first year as an intern, I couldn't hit it. You know, I almost got there, and it was like, but the next year I took so much supplements and I really started I paid attention to my nutrition, and we finally got it.
Yeah.
Right. And
You
so
weren't getting enough in to build.
yeah,
To get stronger.
yeah.
right?
I mean, as a resident, you don't sleep, you're not eating enough, and you're like constantly catabolic.
Yeah, exactly. And during sports, you were probably more supervised, or at least you're more aware of your nutrition.
Yeah. Way more
What
than
were your sports that you played?
swam and water polo.
Water. Okay,
Yeah.
so in the water. And
Yeah,
were there people looking after your nutrition, like your parents?
Not as it is today. Today's nutritional advancements and sports nutrition is like amazingly like advanced.
Well,
actually more advanced than what we're doing in orthopedics.
I thought we were taught. I think we were taught a lot of the wrong things when we were growing up, because the food pyramid, you know, I think is a little backwards to some degree.
Yeah, I mean
Carbohydrates it's the way we think about these things. Really, I mean, we should be using these things, the macronutrients. The carbohydrates should be used for energy. The protein should be used for muscle building, and then the fats should be good fats, right? But those are just 3 macronutrients, and then kind of everything else, which is what we're going to talk about today, all the micro stuff, which is the interesting stuff.
Yeah.
But the macro stuff should be balanced. It's like, get your balance of those with good input, right? Good sources, but like understanding those macros, protein, fat, good fat, and basically like bad fat, like certain types of polysaturated fats, but even saturated fats can be okay because you need them, right? Cholesterol and all that stuff, and saturated fats it can be okay, but everything's balanced. And then carbohydrates for energy. So if I learned this from jiu-jitsu, if I'm just grinding and I'm doing a lot of exercise and I've had a really hard sparring sessions and I'm doing that 4 or 5 days a week, my intake, it can't just be protein. It also has to be a lot more carbohydrates because that's just what I need to be able to perform. But that's how my body's set up. But I never even realized that until I push myself to like basically almost extremis, where I just feel like I can't take anymore, you know?
So you're absolutely,
but only like a very like serious athletic competition can you get to that state.
Absolutely.
It's hard to push yourself.
So for me, that came through my exercise physiology schooling. You know, I got more.
You understood that early.
Yeah, I got more out of my undergrad education on skeletal metabolism about nutrition than we got in medical school.
My dad was my dad is a doctor, and he just used to tell me like your liver will take care of it. You know, like I just think the teaching even for doctors was so different back then. We didn't understand it. Nutrition was like basic stuff.
All this
not
stuff,
that long ago.
All the stuff that I have learned that I'm implementing now did not come from medical school,
right?
And did not come from residency,
right?
It was not part of our orthopedic education at all, you know. And it actually had to go back to a lot of stuff that we learned from, you know, the athletic performance and the kinesiology and skeletal metabolism, the stuff that, you know, I kind of went into my practice having patients optimize their nutrition.
There's gaps. It's like, who's teaching this stuff?
Yes.
You had to look it up on your own.
Well,
I learned from you.
Well, this is why it's been really exciting to now, you know,
I didn't even know there was people. I was looking for people that were teaching on this stuff. And as orthopedic surgeons, we should really know and be experts on nutrition.
I had to go outside.
For sports, there's nobody else that should be doing this other than orthopedic surgeons.
I had to go outside and learn.
Everybody should be, but we're the ones who should be doing it for sure.
Well, the reality is, as orthopedic surgeons, you know, we go through medical school. We all have to do really well. And then when we go into residency, we're kind of like, you know what? We're going to check out of anything else that's not surgical. That hip fracture study that you brought up, right? The story.
You got to pay attention to stuff they're going to test you on, because I don't have time for other stuff.
But when you become an orthopedic surgeon and that patient has a hip fracture that you need to fix, you just say, you know what? I'm going to send it to medicine, and medicine will clear the patient.
Clear and optimize.
Even though we did all the studying and we got good grades on the test, we kind of check out. Right. And we're like, hey, I'm going to fix a fracture. You optimize the patient or clear the patient.
Oh, I got mad when I was a chief resident at USC. I got mad at a junior that was studying the Lovenox dose for somebody who had a DVT.
Right. So
I was like, stop it. And I smacked the book out of his hand. I was like,
tell me about the cephalomedullary nail angle.
Yeah, exactly.
Right.
You learn, if you don't know that, then learn that first. You got to know ortho. But that was just, you know, that's kind of like this old school mentality.
It is though. But here's the problem. It's catching up with us now because now
I want to learn the medicine stuff.
Because we fix something and now we realize, oh man, it didn't heal. There's something else we got to go back to. So now we're going back and saying, hey, you know what? I'm much more thoughtful about how I look at my patients.
Rob Bergmeyer, that was you.
So what?
It was Rob Bergmeyer.
Oh.
I was like, that's who I smacked the book out of. Sorry. I just remembered.
But you're absolutely right. This has been something that we ignored, and now it's catching up with us because the complications and today's era, where it's all about cost savings and quality, we can't just fix. We need to address
they're totally changing all these systems in the government, right? They're cutting out these massive departments, and they're saying, you guys have been wasting all this money. We need to structure this differently, like it or not like it. You know, if there's waste in the system, you got to figure out how to take care of that, right?
So this is
they're restructuring things. And I think what I wanted to talk about today too is about maybe educational restructuring with just understanding what the studies show and how those are based on, because that's where our curriculum as orthopedic surgeons in school and on the boards is based off of studies that surgeons do. It's all peer-reviewed stuff.
So, you know,
it's the work that we do and then we study it.
That's right. So I think education is the most important thing. And I think educating on topics that are going to make a positive impact, and the sooner we get that is really important. And so, you know, this last year was the second year the Academy asked us to give a lecture, an instructional course lecture.
ICL, right?
ICL, instructional course lecture on nutrition to improve surgical outcomes. And then we actually wrote a chapter on this, and it's this year's ICL book. It's a chapter on nutrition. This is something we never got. So, you know, next year, one of our testing for recertification, there's going to be a question on it, right? Which is crazy, because I remember the first lecture that I gave at the ICL, one of the guys was like, is this an orthopedic surgery or is this a general medicine talk? You know, but and then it wasn't until we got into the nitty gritty of showing the data that is impactful in orthopedic surgery that we're like, oh, wait a minute. You know, and I think particularly this concept of modifiable risk factors, which means what can you modify? You can't modify someone's age. You can't modify some of their fracture pattern. You can't modify some of their chronic issues. But what can we modify? So is it obesity, smoking history, nutrition, BMI, all these variables, glucose, these are all modifiable. There was a study that looked at 100,000 joints and looked at all the modifiable risk factors. Of all of them, obesity, smoking, nutritional status was the most predictive of postoperative complications. So now we have to start paying attention. Why? Because now we're in the system now where, particularly if you're in a bundled payment system, there was a study 2 years ago at the Academy that looked at if you have one readmission from a shoulder arthroplasty, it wipes out the profit of 55 uncomplicated cases in a bundled payment program.
Yeah. So that's a number needed to treat, or number needed to one of those statistical tests, but you have 55 healthy people and one complication.
If you have one readmission for
because of the bundle,
because
they happen, especially I do complex revisions. I don't say no when people need help and they need to be revised. I just have a process for getting those people done, but there's still known complications with revisions. And I tell my patients that, they know that, and sometimes you have to go back, right? Sometimes you have to optimize them, and the complications still happen because of those risks, but we still optimize them and try to get them to that state where we can minimize those risks. And when complications happen, we're aware of them, and then we take them back and treat them again.
Yes.
And then you see people get better, right? So it's not one and done. Sometimes you got to go back.
So, most
of the time it's one and done.
Yeah. Well,
hopefully it's,
I view it very differently.
But that's why this stuff is so critical, because of when complications happen, those revision rates do go up, and the complication rates go up, and then more revision rates go up. And that will continue to happen throughout the course of that person's life. And so by minimizing complications, and if you have any way that you can reduce risk, you have that patient that has a healthy, stable shoulder is at very, very low risk of ever having a problem with it, unless it's some type of deterioration of the implant. But we're not talking about complications that are related to like wound healing or, long-term infection. I would imagine that's a study that we should discuss too. What about reducing long-term infection with adequate nutrition?
I've been very fortunate. I'll be participating as one of the delegates at the upcoming international consensus meeting on infection. This is something that Dr. Parvizi puts together.
They need more data. Right. They need more studies.
So this is
hard to make conclusions. They need more data.
So I'll give you what's going to happen.
Serena. You know Serena.
Serena is on that committee with us, and
he's a good friend of mine.
So yeah, Serena is
and he's a genius and a leader. We need a leader, and we need people like that.
Serena will
tell us what we need, and
so I'll tell you. There's two questions that they've been working on for the last 2.5 years. So the way the international consensus.
When was the last meeting? Was it 21?
Yes, it's every 3 years. Okay, so they're meeting this year in Istanbul, and so I'm going to be been fortunate enough to be able to participate as a delegate. And so the two questions that are relevant to nutrition that was chosen 2 years ago, and they did a deep research and looked at to answer these questions were first question number one was, should patients undergoing orthopedic surgery be screened for nutritional status? That's one, right?
That's a good question.
Right. And we all voted on it. We looked at all the data. We wrote the paper on it. And the answer to that question was yes.
Mm-hmm. And they give classes of recommendations, right?
Yes. And so, in the second question, does nutritional supplementation decrease the risk of infection and PJI? And the answer to that question, yes. So this has been something that
seems you may pretty straightforward to me.
Well, here's the thing.
It seems it should be at least looked at.
A lot of things that seem intuitive.
It doesn't warrant this response. No, that's not a good attitude.
Well, the reality is
something that we can improve. That where there's space to make things better. If things are already perfect, then
this is such a low hanging fruit.
Yeah.
The reality is people are not going to really pay attention.
It's not let's talk about if we should do it. It's like how we should start implementing these things.
So now the evidence is very clear, and now this consensus meeting that we're going to be voting on, and it's already kind of everyone agreed.
Maybe that'll make a big difference with these.
I actually
outcomes.
think so. And I think if you look around now, what's happening, around the world.
Plus, if you start accounting for the nutrition in these studies, maybe it'll show some differences that nutrition has a big role.
It's huge
in the.
Well, we already presented this. This is already so. There's always somewhat of a delay from kind of understanding a concept and then putting it into practice, studying it, and then changing the educational aspect of this into our practice, and then the practicality of it being into your workflow is where we're at now. So the data is very clear. What you put into your body around the time of surgery matters. And now we have kind of guidelines and systems to help take that to the next step. Why are people paying attention now so much? Because of the cost of complications and the recognition that this is a modifiable risk factor. That means we can do something about it. So when I sit with my patients now, when you look at the shoulder, let's say you got a rotator cuff tear, right? And someone is looking at you.
I do.
Okay. So
and I had to use nutrition supplements.
Okay, but my point is the algorithm.
I don't have a tear anymore though.
Okay.
I had a really good surgeon who fixed it. I just have to be good and listen to him now.
So when you and I as surgeons traditionally look at a patient, what are the things that we think about, right? We talk about classifications. We talk about, the amount of tendon size, how many tendons are torn, how retracted it is the muscle shriveled up, does that patient have arthritis, what's their age? So we start to
the things that matter, right?
Right.
Like I try to focus on those key things and make sure my patient really knows these are the things that matter.
We start to formulate.
We're looking at the same thing.
Right. So we're saying, hey, look, Mr. So-and-so, Mrs. So-and-so, based on whatever classification you want to use, Rohe classification or whatever, the chances of a successful rotator cuff are this, and the probability of you re-tearing are that. And so, we have some guidelines.
This is
right?
this is what we're dealing with.
This is what we're dealing with,
This
right?
is what we're dealing with.
But there was a recent study that just came out.
Yeah, like you and the patient as a treating surgeon.
That looked at, their nutritional status had a huge impact on their re-tear rate. So there's more and more.
That was a recent JBJS study.
That was a recent JBJS. It was out of Japan, and Japan is really ahead.
It had some issues with it. It wasn't a perfect study.
Nothing is perfect.
Yeah.
The perfect doesn't exist, but these are trends that
But it did show nutrition mattered. And
Clearly.
there was definitely more complications for people who had poor nutrition.
66% of patients.
So how do we know poor nutrition? Getting back to how do you screen? So that other country is going to screen people. Should we screen people then for nutrition? How do we know who should get it? Or, okay, let's put it this way. There might be different realms because with public health, we know that there's different ways that we can treat many people. This is something that maybe is really a public health concern. And like RFK is doing, he's looking at things like getting rid of red. I learned that I didn't realize red was a chemical that affects your brain and it made my kids crazy. And when I stopped giving it to them,
it's not legal.
I cleaned out all of my pantry and I don't give them licorice. I don't give them anything. And I look at it. I don't give them anything that has red in it, these chemicals. And I was not a believer in that. I swear to you. They act different now. Wow, they are much better normal kids. They do their homework and they listen. And I don't know if I'm just blessed, but I saw a distinct change.
That's amazing.
And I tell everybody that I work with, they should also look at the things that they're giving their children because they just say, oh, it's just sugar. Oh, they're just bouncing off the walls. They get sugar all the time. They eat whatever they want. I let them eat anything, but I do not let them eat those types of chemicals.
So I'll tell you something.
And that's something that is based on that food pyramid. It's based on all this old knowledge and marketing. Government was not enough involved in public health, clearly. And they told us sugar was good and, fat was bad and eggs were bad at some point. And now we know mostly the opposite is true. And whole foods is clearly the winner. Whole nutrients are clearly the winners. And even with supplements, still, you can't just have supplements.
It has to be very targeted. So this was the challenge.
Will then fill those gaps, especially when you're undergoing surgery, because you don't know what you need. You don't know what your shoulder needs. When your tendon is trying to repair itself and deal with all of how does healing happen? Do you know? It's magic. We don't.
Yep.
Is that your phone?
That's mine. Let me shut it off.
You broke the rules.
I thought I turned it off.
You broke the rules. No, I'm just kidding. It's cool. Just turn it off. It's okay. We'll keep it. All right. So we were talking about sugar. We just had a phone going off, but it's okay. So I forgive you. So all of our knowledge of these basic principles was, I think, really backwards, and I don't think our parents understood them well enough to teach us, but you listen to your parents, your doctors don't really know. So you listen to your doctor, then your teachers don't really, who knows? Nobody knew. Nobody knew these things. Yeah. And so you figured that out and you went out, you studied it yourself.
I'm still figuring it out.
Well,
but we made a huge impact and we've had a tremendous, look, it's not about me figuring it out. I think, to be honest.
But you figured out it was important. You made that shift, and I figured out that it's important, and I got you here so we could talk.
Yeah, so I'll tell you.
So it is important.
I was in a position to have my background, and be in in a position to be able to bring it all together.
Right.
That's really what it was.
My training and knowledge helped me understand things in a way that I could, without it, I
I
wouldn't be able to
and
get
the majority
to
of
that
the stuff was really done outside of medical school.
So let's talk about the process. So when you were starting to develop this protocol, so maybe you can go kind of through what your protocol is, and then what the actual supplements are, and then what that was like the basic science, lab. How do you make a supplement? I don't even know. Who do I talk to?
Yeah.
Hey, I want to make a supplement. Who do I talk to?
So,
I don't even know. How did you do that?
So when I first started practice, before I
as a surgeon too, you're already operating. You're as a surgeon.
From the first day I started, I had a nutritional optimization for my patients from the beginning.
Oh yeah,
from the beginning.
So you knew right away. You already knew.
Because this is before,
because school did not teach you that.
No, but
I should say orthopedic school did not teach you that. I never learned that.
But you know what taught me that is, I live in Venice. I'm working with a lot of these athletes and bodybuilders. I had a lot of my friends are into nutrition, and so and I take supplements, and I'm about food. To me, it's really an important piece of
bro science works. It does work, right? Bro science does work, but it's just explaining it maybe off. But the bodybuilders know how to get big. They clearly know like supplements, and they know their nutrition.
100%.
Those guys understand.
You would be surprised.
You were one of them.
You'd be surprised the amount of thought that goes into training. And think about it, when these guys are in the gym breaking down their body and they're trying to build, that's exactly what our orthopedic surgical patients are doing.
And they don't want to waste their time either, so they figure it out quick.
When I was training for my swimming or water polo, I ate.
They break down and then they get big, right? We break our patients down,
and then we don't feed them.
And then they got to build. So you're looking at them. What do we typically
do for our patients before surgery?
Atrophy. Right?
What do we tell our patients before surgery?
What do we tell them?
Don't eat.
NPO.
Don't eat.
Don't eat.
Don't eat. Hip fractures. Don't eat.
Right.
Oh, maybe I'll get to you tomorrow.
Yeah.
Maybe I won't. 2 days later. Don't eat. Don't eat. 30% mortality.
I felt great after I had your carb loading the day of surgery, because I took it 4 hours at midnight, something like that. And my surgery was even in the morning, but I didn't feel depleted. I was ready, and I didn't feel hungry.
So the reason for the carbohydrate,
I felt fine.
So the reason for the carbohydrate is your liver has about 150 grams of glycogen in its storage. After an overnight fast, you deplete quite a bit of it. By the time you hit the operating room, even if you're the first case, you essentially lost a lot of the glycogen that's in your storage.
You're going to ketones pretty soon.
And that's just if you were just hanging out.
Yeah.
Except you go into orthopedic surgery. Then you get hit with surgery. So then your body has this hypercatabolic stress response, and your body needs glucose. And your body says, okay, well, where am I going to get glucose from? If your liver is out, it starts breaking down its only source.
I want to show that. How many studies have you published on nutrition?
Well, we've done, last year we wrote the Academy review on it, and then we have a few.
That's the big one. I've been really trying
to
a big one. Show people that they can read this one to just understand. That's the one that helped me.
Yeah, and then
what year was that published? 23.
That was 24.
24.
That was 24.
Very recent.
Yeah,
all this
very
stuff
recent.
Has been so recent.
Even if you look at this one right here, this was really interesting. This was not only is poor nutrition a risk factor for getting an infection, it's also a risk factor for your failure of the treatment. So whether you're doing a urinary retention, if it's acute, or you're in a first stage or a second stage, if you have poor nutritional status, your chances of a successful surgical treatment is higher. So for me, that I do infections for my shoulder arthroplasties, we check, which bug it is, and we put them on IV antibiotics, and we look for ESR therapy to come down, right? And then we say, okay, we're going to operate again. But are you looking at their patient's nutritional status? Are you looking at their albumin? Are you seeing where they are? Because
I haven't been checking, and that's one thing I wanted to see is what would you recommend for, we kind of talked about screening. How should we screen people? Is that something that we can screen? Or if we are going to screen, we're hey, I just want to check this person's nutrition. Is there a guide that we can use to say, let's just check these labs because I'm worried about it? Yes. And then a separate question is, should we be doing that in everybody?
Okay, you already nailed it. Okay. So there's a lot of different ways to check for nutrition, but it's very hard to check for nutritional status just by a simple test. It's not like a scale that you can just get on. The best thing that we have to go by is a proxy, and that proxy is albumin,
which is a protein in
which
the
is
blood.
A protein, but it's a negative C reactive. It's a negative protein. So which means if you have an inflammatory or infection, or you're malnourished, your ESR goes up, your CRP goes up.
It's a reactive protein to inflammation.
But it's a negative reactive. It's a negative. in those settings, it goes down.
Reactive protein.
Yeah, so it
so
goes
albumin
down.
goes down.
Albumin
in
goes
those
down.
cases.
So yes, in the setting of poor nutrition, it goes down, but it also goes down in other things. That's why it's not the perfect test. So majority,
And multiple studies have shown that albumin is not the perfect test. It's just one marker.
but guess what? It's consistent. Okay. So
it's one of the markers.
So now
It's
we're
a
using
consistent
these
marker.
different more tests, which is like you take the albumin plus their body weight, and you can show that patients with not optimized nutrition, they have higher complications rate with shoulder arthroscopy. We see it.
What is the critical albumin level that you look for?
So
3.8 or you go 3.5?
So 3.5 is really below that is bad.
Yeah.
Okay.
That's baseline.
That's like the base.
And then
okay?
is that a number you can get up? Can you treat it and get them up?
So this basically kind of puts it, it's a spectrum. Okay. If you're down here, 3.5, you should not operate on that patient.
Your possible red line. It's like your phone, your battery might die or your car may run out of gas. You don't want to.
And guess what? 42% of obese patients fall in this category, which means just because they're overweight, it doesn't mean they're well nourished. That means they're eating a lot of the wrong things. And then 3.5 to 3.9 is kind of at risk. And then as you get higher, close to 4.0, so that's my goal. I shoot for 4. But there's
no reason to have albumin low. I should have it high.
You should have it. You should
pretty much. I've never heard of any.
Check your albumin. You should be pretty high.
Should be high. Keep it high.
It's definitely in the fours. You should not be right.
How can you raise your albumin?
How?
Yeah.
Just nutrition, high protein.
Protein.
Yeah,
more protein.
Assuming
it should correlate with.
Assuming
protein.
you don't have all the inflammatory stuff going on.
Right.
But if you do
in a normal state, say somebody's deficient.
Now, if you're looking for it to change,
yeah,
albumin takes longer to change. So when I look for quick changes, I should measure pre-albumin.
Mm-hmm. Well, how many days? 3 days?
So
5 days?
Pre-albumin is they got a half-life of two days, but your body takes a little bit of time. So it depends on a lot of different factors, but I've seen anywhere from 3-4 weeks where people are intensely changing to get on supplementation and then they can quickly get it up. And some patients up to 3 to 4 months. So for me, we'll go through this maybe later. I have this metabolic report card that I share with my patients. I say, hey, look, yeah, we talked about your rotator cuff and your x-ray, but here's your metabolic report card. So
and what kind of factors does that have in it? And how do you get all that information?
Yeah, so we can go through that.
That sounds great. I'd love to. Can you pull that
That's
up?
the last slide. Yeah.
Yeah, sure. I like going last to first. So
okay, so yeah, we can
middle
do that,
then last.
Yeah,
just to make it hard for you.
But before I get to that, I just want to just show this because you just
it's cool.
Just one point. This is what we're showing is look, patients who are malnourished. No surprise. If you don't optimize them, they have higher complication rate. That's kind of intuitive. And then what we see is that patients who go through rotator cuff repair, they even need a higher albumin than
more demand,
more metabolically active, more biologically demanding.
Because they have more. They got to heal.
Have you seen the tissues of your rotator cuff?
It's all
you're
tissue
healthy,
healing,
right?
Yeah.
And you get someone who's 50, 60, 70, 80, poor bone. The whole thing is much more affected. So they require a higher on that spectrum to heal. So this, just keep that in mind when you're thinking of like what different surgery. If you're doing a shoulder arthroplasty, you're taking everything out.
I saw you had a difference based on arthroplasty versus rotator cuff, and I want to ask you
So
why.
we'll get to that. Yeah. Okay. So here's the good news. Nutrition, this is a modifiable risk factor. So if you provide patients with supplementation, they actually have less complications.
Boost it up, tank it up.
You tank it up. So that's, again, maybe intuitive, but here's what's compelling. This part. Healthy patients, like we would consider ourselves maybe healthy, even patients who are healthy, when they're provided supplementation around surgical time,
still do better.
They even do better. So that really kind of opened up our eyes to say, well, what's going on?
It's not just the at-risk people; it's everybody.
And this is why, because when you go through surgery,
I felt it myself. You're right. I felt it myself because I know my shoulder was hurting after surgery, and I would get the right nutrition. The only way I got it optimized with the shake, and I was still eating right, but it's really hard to figure that out every day. My pain it literally got better, and it sounds silly and crazy. There's a lot of good
research showing,
but it has an effect on pain.
And look, if there's one slide that puts it all together as far as the science goes, this is it. When you have surgery, it kicks off this hypermetabolic kind of breakdown response. And so in order for your body, and this is what we care about in orthopedic surgery, in order to...
I was just looking at the muscle.
Yeah. but the muscle is the reservoir.
Yeah, at the shoulder, elbow.
We have fat that can give you energy.
Well, it's a reservoir for
amino acids.
Okay.
Because amino acids are what's the determinant variable for tissue repair,
right,
for immunity, as well as glucose
You have to
metabolism.
mobilize proteins from somewhere, and the muscle has reserves that it can mobilize.
When you and I-
The liver helps with that.
When
and
you
then
and
it
I
can
were
go through your
cavemen,
bloodstream.
and we fell down and we broke
It's
our
you
leg.
got to mobilize the troops. Hey, we need more over here versus over there. So your
That's
body
right.
changes. We adapt
So
based
your
on what we do.
skeletal muscle is not just for motion.
Yeah,
From an evolutionary perspective,
it's an organ.
it also plays
Endocrine
a
organ.
very key reservoir for times of injury. So it'll give you those amino acids that you need for healing. And some of those amino acids are called essential, EAAs, essential amino acids. That means your body can't metabolize them. You have to get them from a nutritional source. And unless you have them at the right time and at the right dose, your body will say, no problem. I'll just break down my reservoir.
I already got it. I got it right here.
But guess what
There you
happens
go.
after that? You have muscle loss after surgery, periprosthetic fractures,
It keeps
falls, and then you get all this
happens then
atrophy.
a
For
lot.
me, I do a lot of ACLs. My athletes, they want to get back faster, re-tears. And so we may not talk about a complication, but if an athlete that wants to get back to play faster, for them, every week counts.
But it's one thing I thought about this too, because I went through this myself. It's also not just getting back faster, because that's one thing that people say, like Aaron Rodgers, right? Oh, he got back so quickly, but then look what happened. He kind of screwed it up. So, so it's like, there's still 3 months it takes to heal, and so I don't think that necessarily that's going to change the biology in such a way that it can take a load in a different way. I may have learned that through personal experience, but throughout the course of that process, once you get to that point, for me, it's 5-pound restrictions in your shoulder for 3 months, pretty much with any procedure other than arthroplasty, which is different. But if it's tendon tissue,
tendon is very different.
It's
Tendon
very
is
different
much more
because
metabolic.
it's reliant on those stresses. And so my point is, if you can get to that state where you're just pretty much healed, but you're just taking it easy and you're kind of, I'm good. I got good motion. My strength is good and I'm just good and I'm not going to mess it up. And then you have that mentality, you're going to have a less risk of complications, because if that person is having pain and then they're stiff and then they're, like not doing things because then they hurt and then they're angry and sad and then that sucks. And then they might have a complication.
That's right.
And then they might be stiff. And it's like all of that actually could have just been totally avoided. So just because maybe even the studies that will show like, hey, give everybody this, like check their supplements, give them the supplements, look at the outcomes. Oh, they're all great. It's like, well, great. Like some studies show that just good outcomes. And everybody says, well, why does it show that? If you can get an optimal protocol that does show really limiting complications, that's going to be something that then continues to then look at these details of continuing to fill in those little gaps.
Yeah, that's exactly what we're doing. So we have
optimization.
So we have a study at Johns Hopkins and as NYU. One is at joint arthroplasty, total knees at Johns Hopkins, and the other one is a hip fracture study at NYU with this kind of advanced protocol. There's a lot of good research already done.
So speaking of that, total joints, where do you think this is like the most essential? Obviously, there's role for it. You can make a case for any surgery. Yeah. I talked to a plastic surgeon. He said, yeah, of course, we use this. We recommend this on every case because everything they do in cosmetics should be optimized. But where do you think that this role is most critical in terms of like from a basic science tissue healing perspective? Or is it just as critical in every sense?
I think the nutritional piece is important for every patient, and I think the complications are different for different people. I think it'll benefit different people differently. So if you look at, for example, an ACL injured athlete, they lose quad muscle, their atrophy leads to a significant muscle loss, and it takes them, they get kind of two hits, right? They get a hit from the surgery, and then they get a hit from the injury and they hit from the surgery.
Yep.
It takes them a while to come back. The joint arthroplasty patients, they come in even later, and our athletes, it takes them sometimes a couple of years to get back to their regular strength.
Yeah. This is the chart that really shocked me.
This is, look,
2 years. And athletes, when you make this dip, look, it takes 2, and the studies show that. All the outcome studies on shoulder, I tell my patients, because if I say 2 years, it freaks them out, right? But if I say 3 months, which is what it takes before you can do this, lift your arm up and down, like you're doing 80% by 3 months, and then 20% takes 2 years to get to. Because that, if you really understand this graft, that you get better, you dip and then you get better once you have surgery, but then it takes a long time to get full improvement. So you're recovering for 2 years.
That's exactly right. And so here's the difference. When you have someone who's older with sarcopenia, they have even a harder time putting on muscle because of something called anabolic resistance, which means you need more load.
What does sarcopenia mean? So
sarcopenia is this natural progression of muscle deterioration over age. It's very similar to osteoporosis, but sarcopenia is specifically looking at the advanced muscle aging. and it has to do with the inefficiency of the muscle tissue as we get older to respond to different stimulus, and that's called anabolic resistance, which essentially means in order to get the game time gains, you can still make gains as you get older, but it's a lot harder. And so
it's a bigger hill to climb.
It's a bigger hill to climb. The stimulus needs to be higher, and so the same amount of if your kid was supposed to going to have 20 grams of protein, that would translate to a certain amount of muscle protein synthesis when they consume that.
You should come over and get my kids jacked because they play baseball.
Yeah.
I need to buff them up.
But
and me, I want to work out with you, so I got to get back to it pretty soon.
But it really has to do with the amount of stimulus that you put on.
Sure. You mean like weights or stress or some kind of like physical activity?
You need physical. So if there's one
thing, you can't just lay around and drink protein.
You
can to a certain extent, and it will help you. But I learned that from Huberman. If you have a certain amount of protein and moderate exercise, it's almost as good as exercising. But if you exercise, it really boosts you up to build muscle.
There is no question. Yeah. The most important variable is exercise.
Absolutely.
Yeah. Okay. However, if you're not eating, then you're not going to be able to kind of have the building blocks.
Yeah.
The best thing to do is actually with our protocol that we talk about is, combining nutrition very close to exercise. And so if you're able to they're synergistic. So this is exactly what this anabolic resistance comes to. They're talking about this anabolic stimulus is train, exercise plus the protein. And it kind of, people laugh at the bodybuilders, eating every 2-3 hours, but that's essentially what they're trying to do. They're constantly trying to keep their body in an anabolic state.
It keeps it
in an anabolic state, right?
Prevents breakdown.
So if you're older, you have a bigger hit from surgery, and it takes you longer to come back. And then here's our hip fracture patients. This is where you see. So here's the bottom line: regardless of who you are and what surgery you're having, your body goes through this catabolic hit the first couple of weeks after surgery.
One thing I noticed is all the curves look the same. They're just at a different level.
The slope is different, right? And then they drop down more, right? And then
the slope is different.
And their baseline is also different, right? A 17-year-old football player, their baseline strength is up here. Maybe, someone in their 50s having a total knee or 60s up here, grandma's over here.
And you can see they're declining.
And then when they take a hit, when an athlete takes an ACL injury, even before surgery, we see about 15-20% strength loss before the operation. Once they get operated on, they drop down. So what I was getting at earlier is we can't stop this breakdown completely, but by providing prehabilitation and exercise and nutrition, you can mitigate this. And this is where the difference comes, because you're providing those nutrients at the time where they're most catabolic. So your body essentially, and there's a lot of good studies now, what you put into your body around surgery, it matters.
Yeah.
And most patients don't have that insight.
I like that you guys figured out to give people a shake. You give them a little shaker so they can shake it up and just kind of measure it, and then you have a little pack.
It's very precise. It's a medicine, right?
That was the cool thing for me. It was all this stuff, and people understand this, and the basic science of it makes sense. But what gets people doing it is behavior traits, or making it behaviorally easy to integrate into their life.
Yeah. So we even have so you said something earlier, which I wanted to really say I agree with you, is Whole Foods.
Yeah.
Okay. And so we even have on our program, we have a dietary program that tells patients, here's what you should eat. And I'll do it for you now. We have a muscle centric calculator, which we can dial in.
So you give your patients a lot of information about nutrition.
I give my patients, I'll tell you,
how much do you interact with them?
I don't have all the time. I don't have the time to talk about in this detail.
Yeah.
But we have nutritional guidance information, and we can send them to the website, and they can learn. There's a lot of resources that we provide patients.
Well, are there any resources that I can use?
Yeah, I can show you right now. So if you go to the website right here.
Yeah. Here, let me pull it up, and then you can get it. So, but what I'd really like is a nutritional calculator.
That's exactly what we did. So it took a long time to get this.
Right here.
So, yeah. So
I'm going to open up a little more tequila.
I love that.
Okay. That sounds like a spectacular idea. And we have our tequila.
So, yeah.
How do you like the tequila?
It's very good.
It's Mandala.
It's very good.
How much? So you're a nutrition guy. My plastic surgery buddy came over. He's like, he doesn't drink anymore because he knows too much. I'm like, well, your skin looks so good.
I told you the 80-20 rule.
I can't argue with you.
I told you the 80-20 rule.
Yeah, 80-20.
80%.
Okay. That's a good rule.
Equaling 20%. Enjoy life.
We'll go with 80% tequila, 20% not tequila.
So what I want to share with you, something you were talking about was,
okay.
So the reality is we don't have time to go through all this stuff. So I wanted to create something that made it very easy for people to be able to get the resources in a way that was
it's
practical.
It's a lot of stuff.
And
basic science, like words people can't even.
So by the way,
say.
this website is designed, work with residents. So it's designed to have educational pieces, and all the papers and all the literature is on here. But one of the things I wanted to share with you was, if you go for resources under patients, there's a lot of different.
That's
programs.
the box I used. I used the 3-week course. I did 1 week before, and I think it was once or twice a day.
Twice a day. Yeah.
With the, it was essential aminos. And
So
what does that one have in it?
So the XR supplement,
Creatine.
It's got the combination.
Those are the two big ones, I think, are creatine and essential amino acids, right? Those are the mega ones.
So that's the ones you remember. Yeah, so leucine.
The other ones are just as important?
Yeah, they're all, I mean, it's hard to say if there's one. I get asked this question. And so just to step back a little bit. When you come to think about what to put in these supplements, you have to kind of ask yourself, what is your goal? What's your intention, right? And one of the things that we maybe learned from med school was amino acids are building blocks for protein, and then we kind of stopped there. But beyond that, amino acids have signaling mechanisms, and they can actually help shift the mechanisms of physiology.
Sure, exosomes.
Right, and so exosomes is one step
or peptides
off that, and we can talk about peptides, but you can use amino acids to have an effect that you're looking for. Give me an example. When you eat turkey, right, you get sleepy. Turkey has tryptophan. Tryptophan is the precursor for serotonin, which makes you kind of sleepy. So if I wanted to make a supplement for anxiety or sleep, I would put tryptophan in there, right?
Because it's structurally similar.
It's tryptophan is the precursor for serotonin.
Structurally, almost exactly the same, except for a chemical change of one group.
So
or multiple groups sometimes, but usually like a hydroxyl group or some kind of basic change.
So it's basically giving the body what it needs for that particular purpose. So we don't want but
it has to be that thing to make that purpose. That's like a lock and a key. Otherwise, another key looks like a key, but it's not going to work. It has to be a key.
It's got to be very specific. And so it also has to do with the dosing. If it's underdosed, it's not going to turn it on.
Yeah.
So in order to hit that threshold, it's the best example I can give you is like when you go to the gym. If you go to the gym and you lift just 1 pound,
you just clicked something in my brain.
If you lift 1 pound, your body's like, I went through the range of motion, but I didn't get the stimulus. I needed enough stimulus for your body to say, I need to make an adaptation. The same exact thing happens with these amino acids. You have to tell
your body what to do.
You need to. So, for example, a certain amount of leucine is a key amino acid that turns on, is the ignition for muscle protein synthesis. So that's the code. But then once it's turned on, you need specific amino acids after that will then continue the muscle protein function and synthesis. So that's where the branched chain amino acids come in. And these all have to do a very specific ratio. So for example, the branched chain amino acids, the branched chain are the ones, there's 3 of them, leucine, isoleucine, and valine. Those 3 need to come actually at a very specific ratio, which the community has kind of agreed on 2 to 1 to 1. So this gets a little more complex, but this formulation is based on what's the intention of the orthopedic surgeon.
Yes, like you said, what are we trying to treat with this?
So this formulation,
that's why it's like tear this open, do this for this much time, tell them that's what you're supposed to do, and then it works. Do that.
Right. So, but the science behind it is much deeper.
Right. But you guys figured that out.
Yes.
You did. Like, it's not just, hey, a lot of these supplements, it's just a bottle. How much do you take? It says 1 or 2 or 3 or 4. And then how do you take it? It's like, that's the critical thing. It's not just what it is. It's how much of the formulation, which keys do you need to have, which one, how do you turn it on, and when?
Yeah.
And that's what this does.
And this is where actually the implementation.
I've never seen anything else like that.
Well, because it had to put all of these variables together. It had to have the science, it had to have the practicality, and it had to be presented in a way that our patients can, or whoever's going to use it, whether it's bodybuilders.
So how did you figure out what's important? How did you figure out what to put in this package that you tear open? And then how did you figure out
that? Man, that's probably like 10, 12 years, even before medical school, thinking about this kind of stuff.
Did you write it down?
Yeah.
You wrote it down. You're like,
no, well, I mean, someone was
this much is wrong.
No, well,
like,
someone was a little.
What was your process for once you figured out this is what I want to do. I want to do this. Like, when was it that, because this is a thing now, and that before it was an idea. How did you get it? Like, it took 10 to 12 years to produce
10 to 12,
it,
I mean, 10 to 12
produced.
years to kind of be where I was thinking about what I'm putting in my body that matters for performance.
But that's when your understanding of all this came from. But like, when the idea came, I want to know about the process for getting this in a box.
So honestly, the idea started even before I started practice.
How did you know even what to study? Like the doses, and were you looking at studies and
Dude,
saying,
I'm a geek, man.
You were just like,
I'm a geek.
Obsessing about all
I read a lot.
Yeah.
I was just into it.
Yeah.
I was just
like
curious.
The cars. You were
I was just curious.
It.
I wanted to break it down. I wanted to be like, okay, it's protein, but what is it in protein?
So were you reading papers?
Papers, yeah, a lot.
Textbooks.
International papers too, like a lot from Japan and other places.
How many papers did you read?
Man. Now with ChatGPT and
when I'm doing research now, it's like I'm just like reading, and then I go to another one.
But I have to tell you, the way my mind works, you
got to stay organized.
But
you had this goal, and you're like, I have this goal. I need to figure it out.
Yeah.
And you just
when in pulling this together, I looked at Burns, because that to me was collagen. I looked at NASA. I got people from NASA involved.
Yeah, they're heavily interested in nutrition, because you got to go up there and you got.
When you go to outer space, you lose muscle.
Eat the ice cream.
And guess what happens when you're out of space? You have no gravity.
Rapid bone loss.
Rapid muscle and bone loss. Mm-hmm. So these guys were doing
loading, or with very little load, even joint loading or muscle loading.
So those guys were one of the first guys to implement amino acid supplementation. These guys would hang around in a bed rest model, spaceflight model, which means they just laid for 1 month. They did nothing. Mm-hmm. Nothing. They couldn't exercise. They just lay in bed. And the group that was given these key amino acids, they showed that they mitigated strength loss and they mitigated muscle loss.
NASA studies.
When I looked at this, I said, holy crap, this is exactly what our patients are thinking about, right? And so it was kind of putting really burn patients, plastic and reconstructive surgery issues, trauma patients. A lot of it was sports performance. Like a lot of the stuff that I learned from during college was we were taking supplementation to prevent DOMS. DOMS is delayed onset muscle soreness.
It sucks when your legs are so sore that you can't walk, and you're like, squats. That's DOMS, right?
That's DOMS.
It's just like,
that's
walk.
So that's the.
I should have skipped leg day.
That's never skip leg day.
Never skip leg day.
So DOMS is the subjective side of EIDM. EIDM is exercise-induced muscle damage, where when you get a heart attack, you can measure troponin.
Yeah, you see muscle damage in the blood.
So we kind of see that with our condition, compartment syndrome, right? When you have compartment syndrome, you can check creatine kinase.
Right.
Creatine kinase is the metabolic breakdown of muscle
tissue. Or you can get kidney failure because all the CDK goes to your kidneys.
So you can measure objectively EIDM, exercise-induced muscle damage, by looking at the amount of creatine kinase that is released. Mm-hmm. And so we were looking at this stuff a long time ago with eccentric exercise. With a lot of the first studies were done with soccer players, because soccer is a lot of eccentric stopping. And so you can fast forward to where we are now, you can actually gauge injury risk by correlating it with the amount of eccentric load. And you can objectively, at a laboratory value, look at their CK levels, right? And to kind of put that together. And by putting in the right supplementation, you can actually prevent not just the pain, but actually the muscle damage.
So you're seeing multiple applications with specific factors, like, hey, this is causing this.
I'm like,
maybe
this
that can be, putting all these things together, trying to say like, these are all the important factors.
Yeah, looking at, and we, I don't even have time to, I don't even talk about this.
We have all the time you want.
But
I'm
Let's
talking with so hang out. Let's talk about nutrition for 6 hours.
So, but this is
we can do that.
But this is getting really exciting is because
I kind of
now
want to, actually.
We're using amino acids to shift mesenchymal stem cells. And so now
for signaling.
And there's something called AADT, which is amino acid deprivation therapy. So if you have a cancer, what do you want to do? You want to deprive them. Starve them of that key amino acid.
Take away what it needs.
Exactly we're giving to someone who just had surgery.
There's so much we don't understand about the body.
But it's getting cool now because now we're putting it together. So now, we're talking with. So I'm talking with these orthobiologic groups now that we're now studying amino acids in orthobiologics and enhancing the orthobiologic potential by increasing the mesenchymal stem cell activity. So that's already been shown in a lot of rat studies, and now we're starting to now put it into human studies.
Yeah, stem cells are cool too. I think what we got to figure out how to turn these things on, which sounds like that's kind of some of the stuff you're interested in, is turning some of these factors that can affect healing in a way that is very biological, and you're basically hacking. Biohacking is like the new term, right?
Biohacking, biomodulating.
Yeah.
So
why not?
So
it
yeah,
doesn't hurt, and we understand it better. You understand the mechanisms. I always love that word, mechanisms. In chemistry, you learn mechanisms.
Yeah.
When things explode into the other, and then something happens.
The coolest.
You got to know how that happens and what the.
I don't.
What
we're going all over the place, but there's a lot of good. There's a lot of good mechanisms.
Well, we'll come back to wherever you want. Where do you want to come back?
So I just want to. I guess since we have this up, what I want to get to is. The formulation was based on what.
Yeah, I really want to talk about the formulation,
right? And so we have things in there like creatine monohydrate, right? That's where a lot of the athletes are using for recovery. But so now
creatine has been around for a long time.
It's one of the most
essential.
commonly studied, and it's safe. And so,
what do you think about creatine?
It's in our supplement.
What do you think about elderly people taking creatine?
So it's actually been shown for mental, cognitive, as well as muscle.
What do you think about women taking creatine?
I think there's nothing wrong with that. I think the only issue with creatine could possibly if you have severe kidney issues, but
that's pretty much it, right?
That's pretty much it.
Like if you have a kidney dysfunction, or if you're even if you're at risk for kidney dysfunction,
GFR less than 30.
Does it affect your do you know if it affects your kidneys in a way that can be detrimental if you don't have kidney damage?
If you have,
it's only really if your kidneys are not working that it can't handle all that creatine, and then it backs up.
Yeah, but the dose of the creatine at 3 to 5 grams a day,
it's pretty minimal.
It's totally acceptable.
We used to give Vanco to people with kidney failure.
Yeah, and I'll tell you that
Vanco is excreted by the kidneys.
Yeah, I mean the old school days when I got into creatine, we'd load with 20 grams for a week, and then we go down to 5.
Yeah, a lot.
Now
right?
you don't need to load. Now we know that just a 5 is adequate. You don't need to do that super saturation.
Yeah, some people say like take a lot of creatine, but I don't know about that.
5 maybe is really big. 5 to you're for your weight you could maybe do a little more, but 5 is not a big deal. But this is what we're kind of talking about.
It's just maybe not kids. That's it. Like kids and people with kidney failure.
I think
the studies show like kids probably shouldn't be loading their.
No, I wouldn't recommend kids. I don't think anyone should actually load with creatine. I think
no. I mean like loading their kids shouldn't take it.
Creatine or
yeah.
Yeah, I don't know if there's a study that looked at
like maybe teenagers, but I don't know what the recommendations on in terms of age. But
I don't think there's a cutoff for age, but
adults.
I don't think like someone like a teenager.
Somebody who's lifting weights, it's okay.
Yeah, but I mean, I don't know. I started lifting weights when I was 16, 17.
Because it's about building muscle. It gives your muscles more energy. So if you're trying to build muscle,
ATP, yeah.
And so like kids shouldn't really be trying to build muscle, so they shouldn't really take creatine. They shouldn't need as much. Women. If they're lifting weights and they're exercising jujitsu or they're just lifting weights doing fitness classes, will benefit from it. More energy, better recovery, better cognition. They'll feel better, and they just have their body has what it needs as they're going to Pilates class.
Absolutely, so I think particularly for women's strength.
I talk about creatine all the time with my patients, and almost none of my women patients, female patients, take it. And so I educate people when they're trying to like build their body up from surgery. It's pretty much during phase 1 strengthening. I start getting them, really like creatine, protein, but like the whole time I'm emphasizing it. But I always reinforce it at that 3-month follow-up. Like this is the time we're going to start building. Now you're going to see that trend upwards. And if it's not trending upwards, why? Or like, is there something that's limiting you, right? It shouldn't be your nutrition. Hopefully all those factors, like I've spoken about, like these pillars to build the successful outcome with surgery. I'm one of these pillars. The patient is a major pillar with their behavior and like their comorbidities, really, like, if their heart is working well. And then another pillar is like these like not small things, but like unknown things like nutrition or things that can be affecting like their pain and how like what their past was. Like we spend 15 to 20 minutes with them, and then we end up obviously getting really deep into those details and getting into their life, which is important, but you can't go through everything. So what do you think has helped you with like explaining this to patients? Because it's a lot to go through.
So it's a lot. So this is one that you brought up earlier, was this muscle centric calculus. So let's do yours right now.
Yeah, exactly.
Okay.
So this is good.
So this is something that you go through, and
when you talk to a patient in the office,
I'm actually not doing this always with the patients. You don't always have the time, but
they have access to this.
They have access to this
because you're the nutrition guy.
Well, so, but I also, so here's the reality.
I'll fill this out.
Yeah, fill it out. So,
I'm not going to give you my real weight right now.
Put in your ideal body weight. Okay,
we'll say 190.
Okay.
I used to be 190 before all these injuries. All right. That's fine. And then I'm not gonna give my real age.
So the reality is
Close enough. So okay, can I click?
All right. So this is
it's red. That seems bad.
So no,
that seems like a lot of fat. Is that me?
So this is not a weight loss. This is for the 6 weeks around surgery.
Okay.
This is the caloric along with the macro breakdown that your patient should be eating, or you should be eating, to
like
put on to maintain the most amount of muscle.
Oh, this gives you the recommendations.
Yes, this is you. This is protein, fat, and carbs. And then
I gotta eat
we'll email you. Then we'll email you foods to eat.
Hang on, let me go back to that.
Okay.
So macros, and it gives you a percentage. So
it's really, all dialed in.
It's not that many carbs. It's like pretty equal, and it's definitely not that much fat. 100 grams of fat. So, but it's pretty like a triangle. It's mostly carbs and what is that? Actually, not that much protein. So it doesn't seem like, I would expect more protein than that.
194 grams of protein.
So that's great. Okay, so then I'm looking over here in percentage wise. No, so that's because that's here. Calories, and there's less calories from that.
So look, I see. So your daily, so you have almost 200 grams of protein. 194. That's a lot, right?
Yeah. Oh, so the food pyramid is still accurate.
Well, I think the food pyramid, you're looking at the proportions,
because that seems like a lot of carbs.
Because when you're healing,
that's what you need.
You need some carbs, like you're right. But also this is the more peripheral. When we email you the foods, the carbs are specific carbs. This is a low
glycemic.
This is a low glycemic, anti-inflammatory, low sugar diet. Okay, so this diet was based on a lot of the studies that showed which are the diets that are anti-inflammatory and help preserve muscle.
I see.
So this is something that you would have to go to some nutritionist to get this.
Right.
This is free. You go on the website. So if you just do this alone,
xrscience.org.
Yeah. So if you do this just alone for your patients, that's going to take them. There's been studies that show improving patients' nutrition to this intake will significantly improve their results.
That's cool.
So we have recipes and stuff. And so
what do you tell them is the most important thing that they do? Because some people are like, Doc, is this important? Do I need to do this? Obviously, you say, well, if you want.
Well, look, I don't,
what do you say?
I kind of don't like the question of what's the most. I think, look, there's no magic answer here. You got to have good indications. Your patient, has got to comply with the therapy, not overdo it, not underdo it, right? They got to eat whole foods. They got to exercise.
With regards to nutrition, what do you think is the most important, like critical time point or time around like surgery? Would you say before? Is it after?
Yeah,
is it for a week?
I'll tell you,
is it for 6 months? Is it a year after surgery? When is the most critical?
The most critical are the 2 weeks after surgery. No question about it.
That's what it seems.
Those are and I'll tell you that based on a study they looked at 400 trauma patients. These are the worst group. This was a JBJS study. Took 400 patients that came in, 200 and 200. They came in train wrecks. The 200 that got amino acids for only 2 weeks.
Oral supplements.
Amino acid supplementation.
Oral supplementation.
Yeah. Amino acid supplements for only 2 weeks. That group had better union rates. Fracture union was better. They preserved their muscle, and they had significantly lower complications. That's only 2 weeks of supplementation. So your first 2 weeks out of the gate, and this is what's really important, what we're seeing with these studies, is how you come out of the gate is reflective of how you're going to do even 2 years down the line. A lot of the knee arthroplasty papers have shown this, where you come, that initial drop after surgery, you're still going to have it. But when you're well nourished and you have a lot of these amino acids and you have more resilience when you come into the surgery, you don't drop as much. And then your ability to get back.
It's a better starting block.
Yeah, and that changes your trajectory even 2 years down the line. That was the follow-up in the JBJS paper that basically showed not only the winner of the 2020 Ranawat Award was a paper that showed perioperative amino acid supplementation, decreased pain, faster functional recovery, and less muscle loss by ultrasound in the first couple of months.
Yeah.
A follow-up paper to that was 2 years later. They followed those same patients. 2 years later, the patients that were not supplemented never caught up.
I think it really shows that, if you have, we don't really know we have an idea of what's in there and what's healing, but it could be an incorporation, having exactly what your body needs at that critical time period in order to incorporate the right way.
We have reverse engineered this, right? We basically said, what is it that we need from orthopedic surgical recovery? It's 3 things. We want to preserve muscle. We want to have bone and collagen synthesis.
Yes. And those things are hard to do.
And those things are definitely hard to do.
You got to turn the right keys on.
But if you put them all kind of in kind of a very specific targeted approach, this is where the formulation was kind of based on, is to say, what are the factors that we can control, and how can we target
modifiable risk factors?
Yeah. How can we target our formulation for those reasons based on all these studies?
Yeah.
So that's how we kind of came up with the formulation. So I don't think this, XR is just about the supplement. It's really about the program, right? Get on this. So the second I see my patients, I tell them, look, start on this dietary recommendation, get online, and then whether they do the supplement or not, that's their choice. But I think modifying their nutritional habits.
Yeah.
Look,
behavioral changes to get you primed to face those same behavioral changes after surgery.
The conversation I have,
got to be ready.
Look, if you were my patient before surgery, ACL, rotator cuff, I have the same conversation with them. I said, look, I'm going to treat you like an athlete, and you have a championship game coming up, and that championship game is your surgery. The stronger you are, the healthier you are, the more emotionally ready, fit you are, the better you're going to do. And so there's a whole game plan that I have for my patients. I have prehab exercises that I have them do, even for rotator cuff. We have exercises that they do to kind of strengthen their deltoid. Isometrics. Isometrics are a really great way of training, because you can stimulate the muscle and you don't injure the tendon.
Exactly, without risk of injuries, isometrics.
So I get them on isometric training before surgery. We change the nutritional stuff.
Yeah.
And then we bring in the supplement right at that key point. The reason we start 1 week before, there's a great mechanistic study done where they gave patients who were going to have total knee replacement. This is Hans Dreyer. He's like the guy who really put this on a map, where biopsied the skeletal muscle at the time of knee replacement. And the patients who were given the amino acid supplementation for a week before, their satellite cells, which are the muscle stem cells, had increased compared to the group that didn't. Those patients went on to have less muscle loss and faster functional recovery. So now we're seeing the mechanism and the rationale why to kind of pump your body or prime your body with these amino acids, because your ability for the muscle resilience actually goes up.
Would you say that there may even be people that are nutrient deficient that have adequate or normal albumin levels?
There are people who have
that are nutrient deficient but still have normal lab values? I think that's been shown.
I think yes,
that you can have albumin that's normal, but you're still nutrient deficient. So it's not the only marker that has to be high.
So I couldn't agree with that more. There's so many variables that go into. So now,
and a lot of them we don't even know. It's like take zinc. What are my zinc levels? I haven't had them checked. Not recently.
So I'll tell you. Maybe go back to that last slide, because I think this is where I think it's important. So now there's something when you get kind of nerdy about describing the terminology
as much as I can
of this. Okay,
it's just I need people that will talk to me.
Okay,
about nerdy stuff.
I can geek out with this stuff with you.
Let's do it.
But
we can play Mortal Kombat later.
Yes,
we'll nerd out on science and then work out.
Yes, all of it. It's all good. So
all right, there's your slide.
So as opposed to saying,
let's see how you did in school. No, this is the one I like. I wanted to screenshot this. All right, I like this.
Yeah, this actually I had people at the academy and screenshot.
I want to put this on my wall in the office. So look at it.
I think this is important because this goes beyond just the rotator cuff tear size or the amount of arthritis that they have. Right. Mm-hmm. This basically is the patient's report card. Okay, where this is even more than just nutrition. These are some of the variables. By the way, all those, what I have up here are all based on studies that have shown poor outcomes. So
blood sugar, no question.
So albumin, I check on everyone above 55.
Vitamin D, no question.
Okay.
Like all of these things are critical.
Right. And then you can measure the GNRI is this newer way of where you take albumin and you stick it in this formula
risk index.
And you put in their body weight. It's a combination of both. It's been
so it should be high.
The higher the better. And
so it's based on albumin and other factors.
And their weight.
And their weight.
And the higher the number, the better. But what's interesting is this is where I was telling you the difference between a shoulder arthroplasty positive outcome versus a rotator cuff. The number to hit for a rotator cuff to have a better outcome, your nutritional status based on that needs to be higher because it's more metabolically demanding than someone who's having a total shoulder.
I wonder if the same is true for anatomic total shoulder versus a reverse with a tendon repair. Because I feel like anatomic relies more on tendon healing and tissue
100%. An anatomic shoulder is got pieces of a rotator cuff component in it.
Yeah, tissue 100%. Healing.
There's no question about it.
80% of it is a soft tissue operation.
So, I think when
maybe 7.
I think when you and I talk about that, we're kind of talking about maybe soft tissue balancing.
Yeah,
but
still, just the work and what you rely on, the tissue healing and how the shoulder works.
That's right.
Is reliant on tissue.
And
healing.
So the amount of
whereas a reverse, if your cuff fails, it still functions.
I don't repair the subscap in half my cases.
Yeah, I repair it, but that's why I just kind of treat all of these things the same. It's almost like saying, well, which cases of your shoulder that you're going to do surgery on should you recommend optimization? It's like, I say I recommend it on all of my patients, and then they can decide if they want to do it. Hey, Juli, we're still recording.
And I think every single patient benefits.
He loves you so much.
I think patients respond differently. But so here are the other ones. BMI, actually, if your BMI is too low, if you're super skinny, you'll have higher complications. So there's something called the obesity paradox. Yeah, where if you're a little bit overweight, it's actually for shoulder arthroplasty, not hip and knee. A little more cushion. Well, it's a little bit of cushion.
And you have more load on your bones and typically less osteopenia and osteoporosis.
Correct, correct. But once you hit 40, then you start creeping up.
Yeah.
Okay. But actually being too skinny is much more of a problem. Mm-hmm. So that's where BMI comes in. Then I look at metabolic health, which is a little bit different than nutritional status. Vitamin D, right? You could have someone who's a big bodybuilder, right? They look huge, right? But they're vitamin D deficient. I get it all the time, believe it or not. Mm-hmm. I check vitamin D on all my patients, including ACLs. You'd be surprised.
So you are checking vitamin D?
Every single patient.
So you check vitamin D, you check CBC, you check a BMP.
Yep.
And then do you get any more labs? Albumin?
I check albumin on all my revisions and patients above 55. Under 55, is the likeness of having low albumin is...
just say take XR and you'll cover yourself.
Well, I just tell them, nutrition, I recommend nutrition to everyone, whether it's XR or not.
I had good nutrition. That's why I was shocked. I'm like, I'll take your XR. I'll look at, this stuff. I really was like,
but
I was surprised.
Yeah.
I was surprised. And I'm a surgeon.
Did you check your vitamin D?
I did, and I was low. And I take vitamin D supplements. All of these things I didn't even know until I checked. It's biofeedback. It's like knowing how the state of your body. When I was a kid, I thought this. I needed a little monitor that can check my blood sugar and it can check almost because they'd be like, all this stuff's in me. What is it? I don't even know what my levels are.
So we have vitamin. So we put vitamin D in XR to cover that.
Yeah.
In case they don't take it. So this is what's been shown, particularly rotator cuff. Vitamin D less than 20, higher retear rate. Hyperlipidemia has also been shown.
Is it enough vitamin D to correct a deficiency, or it's enough to kind of add something to it? Do you know? Did you guys look at that at all?
Yes. So our patent is based on the vitamin D along with something called calcium HMB. Those are synergistic.
Hydroxymethylbutyrate.
That's right. The combination of that is what mitigates muscle loss. So that's a very important. So that dose is based on that patent. Okay. But for all my patients, I recommend vitamin D supplementation. I'll tell you, I have every single patient. I'm going to say it one more time. I have every single patient that I'm doing orthopedic surgery on take vitamin D.
You have them all. You recommend taking it.
I only check vitamin D to let them know where they are on the risk score. Because oftentimes I'll have a patient who's got a low vitamin D level and I say, look, time out. I'll do your surgery. But once you get your numbers better. So this is where I use this report card. I use it to pause. And this is where I know we all want to operate, but I think we're going to have much better outcomes. And to tell you, our organizations, and we know how hard it is now with the cost savings, we're not going to be rewarded by how many cases we pump out in an organization. We're going to be rewarded by how many complications we avoid.
Quality.
Avoiding complications.
Yeah, absolutely.
So I think if you tell your patient, Ms. Jones, I'm going to wait on operating on you until your body is strong enough to have a better outcome.
That's probably what's best. You got to make arrangements. Ms. Jones, make arrangements so you don't have complications. Because if you have complications, you're going to have a lot of problems. You're going to have many more problems than just that one complication that you were going to have.
So that's the metabolic report card. If someone has a history of diabetes, I check their A1C. If their A1C is off, Then I go to fructosamine. Fructosamine, I don't know if you're familiar with fructosamine. Fructosamine, so how,
I don't know how it's involved. It's liver. That's I know fructose and I think of liver. That's it.
Well, you're close. Actually, so hemoglobin A1C is basically how much glucose was hanging around your red blood cell.
Attached to the blood cells.
The
it's a
life,
long-term marker. Right?
The life of a red blood cell is 120 days. So it tells you what was their glucose metabolism and their control over the last 120 days. It doesn't tell you
because sugar glycosylates things. It attaches to things. And if you have a lot of sugar, it's more likely to be attached to everything.
But this is where Dr. Parviz's group basically showed fructosamine, which is an albumin marker. It's much shorter. So you can have someone who their A1C seems to be okay, but if you check them and their fructosamine is high, those patients have the highest complications. So you can get a false negative by thinking their A1C is good, but you got to check their fructosamine.
So these are some of these factors that we might not be fully understanding why some
this
lab
is the more advanced
look, because we're not checking all of these things.
So this is what I do for all my patients. So I probably...
You check fructosamine levels?
On my patients who have a history of diabetes? Absolutely.
I didn't even know it was a lab you could check.
Yeah. It's
standard lab?
Yeah. It's been a game changer.
Okay.
If you look into...
Does it help you understand sugar, like blood sugar metabolism better? How does this number help you understand? It help you understand their albumin?
No. Fructosamine tells you about how much glucose was on the off the liver protein. What I'm saying is...
But how does that number help you? I don't understand like how that value would help you.
Think of it as a more sensitive test because it tells you about your glucose fluctuation versus 120 days of getting it off the red blood cell.
It's more more sensitive than the A1C.
So look, if you were to if I were to check your blood sugar A1C, it would tell me how you did over the last 3 months, right? But it doesn't tell me how you did over the last couple of weeks.
Right.
Right.
Exactly. We don't know that until
if I check your fructosamine, it'll tell me how you did over the last 2 weeks because the half-life of fructosamine is only a couple of days.
I see.
Does that make sense?
Yeah, it does.
So if I'm going to correct someone, and this happens all the time, I see someone and their A1C is like too high, right? How long does it take to correct their A1C? It may be 2-3 months.
Yeah.
They say,
but it's changing along the way. It is changing.
But doc, I've been doing a good job.
Right.
Have you really?
Yeah.
Let me check your fructosamine. And if it's
then
loud, then I know
what direction they're in.
I've also cut it the other way. And this is what it's called hidden diabetes, where you have someone who's got you think a normal or acceptable A1C, and then you check the fructosamine is high. So they did good the last 3 months, but the last 2 weeks they've been eating like crap. Oh. That's how you pick it up. That's been a huge game changer.
It's like when CRP, it's like ESR, it's one thing, but then CRP gives us this tighter view of
this
the
is
changes.
much more. So this is the stuff like I'll be at the consensus meeting. This is going to come up. Again, this is some of the stuff that's more nuanced when we talk about the metabolic aspects of our patients.
I see. Do you think that this type of regimen can have any effect on opiates?
Well, there's
on pain protocols.
There's definitely good literature.
Have you guys done studies on that yourselves?
There's definitely good literature showing that patients who are better nutritionally optimized, and there are some supplementations through the inflammatory pathways that decrease pain. So pain.
Do we know what those factors are? Like the actual, that pain pathway? Are those, is that established?
So the pain pathways, most of the studies are done on omegas as well as BCAAs.
Branched chain amino acids.
Branched chain amino acids, BCAAs. Actually very similar to what was with DOMS and muscle soreness that you saw with that. And then there was a recent study that looked at the diabetic neuropathy model where branched chain amino acids actually decrease the pain. And there's
the key may be branched chains in that association with pain.
Yeah.
Is that
in terms of the essential amino acids? There's a specific, they looked at the nerve receptors, the nociceptors. And this was a mice study. The group that had decrease in BCAAs, their nerves were more hyperreactive. And when they were
more excitatory, easier to stimulate.
More excitatory, that's exactly right. And then when they were provided the branched chain amino acids, they actually had less pain. So there is studies already showing, and even in that 2020 JBJS study, those patients had less pain, checked by VAS scores. So there's definitely something. I mean, I don't know what your experience with pain was after surgery, you know,
I didn't have much pain.
but it's hard for you to know because you only had one side done, right? And you didn't have supplementation
Yeah.
with and without, right?
But people complain
Yeah.
of a lot of pain after
No,
surgery.
but my point is,
But I've actually been seeing a lot less pain. I don't hear a lot about pain.
Yeah.
You know, and I do multimodal pain management.
Sure.
So I give 4 different types of pain medicine. So they don't have to take all of one.
Yes.
And the opiates are last.
Yeah,
You know, it's like
I'm
do
with
all
you.
these other things. And I use ice machine. So I say, which is true, the primary modality for pain is rest and ice.
yeah, and
And then
inflammation, bring, you know,
getting the
modulating
inflammation down. And so it's icing that, and it's like not moving too much
Yeah.
because that brings all this irritation. So just listen to what I tell you, do those things. And like mentally, you have to be prepared for it because pain is a giant mental component of going into
Sure.
surgery. If you just think, if you're scared and you're just like, it's gonna hurt. And yeah, of course it is gonna
Yeah.
hurt. And then it's gonna hurt more. And then if you're not doing those other things, it's gonna hurt a lot. So pain for me has been this kind of like malleable understanding of what people are going through because I experience pain different than everybody else does. And there's people probably that feel similar to I do. And some people experience pain very minimally. It takes a lot of stimulus. And that's, I think, me. And then there's other people that are very sensitive and that's just their life. And you can't compare because people experience life differently.
Yeah.
And so I just have to understand them because that's that person and it's how they're dealing with pain. And I am going to be involved in that. So I'm trying to understand them. And so once I understand, is this somebody that is going to be able to deal with this type of stress in their life? That's a big step one to getting them in for surgery that we're assessing. But then I give them all of these tools that can help them. So I say, this is the surgery that can help you. Let me know if that's something that you'd like to do. And then they will do that if that's something that they want to sign up for, and then they get information about it. So I provide information for them and then they make a decision, and usually it's pretty much that day, and then they need to think about it, and obviously they make final decisions on when to do it. They have to make arrangements, but this is all how, you know, elective surgery goes, as you know. And then I tell them, they all, you know, almost everybody always asks pain. And I think it should come from me. I tell them about these things because, you know, it's a very relevant part to going through surgeries. Like,
you want to know what you're doing.
They want to know how to deal with this pain. And so it's the icing, getting inflammation down. And then it's, giving them techniques on how to take the sling on and off. So we have OT teach them. So they're not just like, I don't know what to do, and so I'm not taking my sling off because that can cause problems. So each one of these things has to just be given and addressed, and then they can have some type of paperwork or some kind of video that they can watch that they can refer to. But that's all through me, and it's all what I'd like to do for them and giving them the tools directly through me so that they have what they need to get through this process until they see me at 2 weeks, and then we can figure everything else out.
Well, you know, look, when patients come to us,
but they need the tools to get through it themselves.
They're looking to us for hope. They're looking to us for guidance. They're looking for us for reassurance, and they're looking to us to guide them through this very scary process, right? And so I think the more,
and somebody who's confident that has a plan is very helpful, because it's like, I'm going to listen to that guy because he knows, he's seen it. And if you're confident and you've seen good outcomes, you know, and patients listen, I tell them, if you listen, things, you know, basically should go well.
You know,
just follow. Trust
we
the
live in
process.
LA, and I have a lot of
process.
we live in LA, and we have a lot of demanding patients.
Yeah.
And I'll tell you, having a demanding patient population has helped me.
Sure, it pushes you.
It pushes me to now actually push the patient. And I say, look, if you have these expectations of me doing this operation on you, I have to tell you, we have to be teammates. And your outcome is partly dependent on my hour or 2 hours of work that day, but really the rest of it is on you.
Absolutely.
But it's my job to guide you, give you the resources, and we need to be in this together.
Absolutely.
And from
the bat, when we're from the start, when we're both agreeing,
from the get-go,
we have to agree on diagnosis first, and then we have to agree on treatment, and then that process starts.
And then I show them, look, you know, I tell them, look, like the athlete, you're gonna have to work to get the outcome that you want. I will work on my end to give you the resources and make sure I'm technically doing the best thing that I can for you. But all these different variables, whether it's exercise or sling, you know, management or nutrition, when I have that discussion with them and I provide them with these resources, they're so happy because they're like, Doc, you actually care.
Makes it
you have
easy
this
for them
whole
too.
like program, and this is something, these are resources that
it's a hard process. I don't want to figure out how to take this, or like how to find, like, what do I need? It's like, just give me the stuff. Tell me what's important. I don't want to go search for it.
We're at a challenge between wanting to provide all these patients with information that they need to have.
Yeah.
And also we have the reality of the limitations of time in our practice.
And overwhelming them. It's like too much. It's like, what can you focus on?
And this is where I think having this like calculator that breaks it up and sends it to them, having the website, having piecemeal things that are provided in a language and in a manner that's effective, right? Patients are not going to always change their dietary habits, but if
human behavior is one of the hardest things.
However,
to change.
If they know good, they're going under the knife. Maybe for the next 2 or 3 months they will.
But they need to. You can't force them, right?
But I'll tell you, I've seen patients come back and their families have gotten on the dietary program. They've changed. It's really exciting to see, like, beyond just their surgery, how much it affected different aspects of their life. I have patients where, like, you know, I have a lot of like vegetarian patients, you know, I'm like in Venice, they're like, you know,
it's LA,
right. You know, and so these patients, they think they're doing the best for themselves. And I'm not against plant-based.
But they might be deficient in some way.
They are deficient in unless they're supplementing.
Yeah.
It's very hard to get that much protein into your diet with a plant-based diet. You can get it, you know, you can definitely get it, but you have to supplement. You got to really be mindful. And so a lot of these patients who think they're doing, you know, good for themselves, they may be missing out on things. And this is an opportunity for us because our outcomes depend on not just the anchor or the type of shoulder implant that we put in, but these other variables are probably more important.
So what do you think it's going to take to change minds on this? Because I brought this up at a Grand Rounds I think it was 2 years ago, and I got laughed at. And I think with time, it must have been a year ago because it was last year, 24. But, you know, I read your paper and I was kind of looking at this and I've been asking people, and there's not a lot of common knowledge, even in orthopedics, from specialists, unless somebody is specifically interested in this and finds it out on their own. I've been bringing this up to a lot of colleagues and people across the country and at meetings, and I'm sure you get a lot of this too. They are probably people that are in your circles know about it because they may know you, but there's not a lot of awareness. How do we change that? How do we change minds with orthopedic surgeons? Is there something that you think that is going to be through studies? Is it going to be through certain types of studies? Is it going to be through just like awareness of like, these are the studies are actually out there, you know? So it's not that there's a lack of data. There is a lack. There's always gaps, but there is enough to say we should look at this further.
So that's a very good question, and it's a complex question, and I'll tell you my thoughts on it. Number one, there has to be incentive. Okay, there has to be incentive. Like, why should I take another 5 or 6 minutes out of I'm already 45 minutes behind to talk about something? So that's one. There needs to be enough incentive, and I think recognizing the association between poor outcomes and realizing the cost. Unfortunately, it's money.
The cost of poor outcomes is
so what's happening now is the cost of poor outcomes is being much more recognized, and the focus on modifiable risk factors is becoming something that now we are slowly starting to pay attention to.
We don't want the return to the ER. We don't want the return to the hospital. We don't want readmissions.
Right. And so readmissions are a big problem. Complications are a real big problem. And in today's world of value-based medicine, this is where I don't think it's going to actually be that much longer before this becomes standard of care. Like, why? I think the question is going to be knowing what we know about infection, knowing what we know about complications in wound healing and non-union, and knowing that this is a modifiable risk factor that not only for sure affects people who are malnourished, but affects even the healthy people. The question actually is going to be, Dr. Stone, why would you not do this?
I do it.
So I'll tell you the answer.
I recommend
I'll tell you the answer right now.
Them,
the answer is, so orthopedic surgeons are not educated enough on this, and two is a cost. Right now,
I was going to bring up cost.
The cost is to our patients right now, and that's something that.
Do you think this is a cost of convenience? Is how I look at it, or do you think this is a cost of quality?
Both. I think both. And I think, you know, look, you know, there are different costs.
Because this is not covered by insurance right now.
Not yet.
So,
but I think at some point,
and it's not $5. You know, it's significant, but it's not like PRP prices.
But I'll tell you, there's different spectrums, and I don't
Depends
think
how much you care about your health.
And I don't think also that you can try to do this through different modalities. Even if you just did the muscle centric calculator and you just ate better, I'm happy with that.
Is there a way somebody can? basically go through the XR nutrition program and be as optimized without opening the packets up? Can they go to GNC or Vitamin Shop and can they measure all their doses and they can fill up their own cups and say, I'm going to do the 1 week course?
The very first day, the very first day,
they can do that though.
The very first day I started practice.
Yeah.
Okay. I had a list of supplements that I told my patients to take. First day. Okay. And it's like, look, creatine was on there, glutamine was on there, arginine was on there. And there's another product called Juven, and that was on there. And I used it, and that's been around for some time. I've heard of Juven. Okay. And Juven is very good, you know, except it didn't have some of the stuff that I knew was also helpful. So what I had my patients do was I would have them take that product and I would add all the other stuff to it. And then they would be like, Doc, I'm going to GNC. This one is strawberry. This one's chocolate. Where's the sourcing? Where's it coming from? And so that's where I realized, okay, look, we need to take control of this. I don't know where they're buying it from. I had a list of Amazon. I was like, just go to Amazon and get it, right? And then as patients came back, they're like, hey, I feel better, but it cost a lot. It was all these different flavors. You know, it was great, but it was like, it was confusing that I had the right scoop.
That's a lot to do for like.
But my patients did it because they were into it, right?
Yeah.
That's where I was like, look.
And there's nothing else. It's like, well, you can't go buy it. So how do I get that? You got to go measure it.
So that's exactly what it was. So I was like, you know what? I'm just going to put this together. I'm going to do the science behind it. I'm going to do the research behind it, get the highest quality stuff, make sure there's science behind every ingredient and put it at the right dose and provide it in a package that is simple. That's it. There's a story. I mean, that's how it started, you know?
And I love the packets because I just go, shh.
That's right.
I just pour it in and it doesn't even spill. You guys got that right.
You got it. Yeah.
Do you have other critical or key members of your team that you work with through that company?
Man, listen.
Have you learned just by being as part of all this?
Are you kidding, man? I have learned. So, you know, I have a full orthopedic surgery practice from 7 to 5 or whatever. And then the second that closes, a whole nother part of my brain turns on, you know? And so that's been the challenge of, you know, outside of my own time, you know, doing this. So it's like doing this stuff. It's like the stuff you're into, you get really into it. Yeah. So this had nothing to do really with like, you know, like surgery really.
Yeah. But something you saw is you believe in it and you can,
because I saw it worked.
Yeah.
Because I knew it worked, you know, and then I also saw
bro science.
Yeah.
Well, but now you got to figure out the actual science.
There was a component.
Science.
There's a component of that. Now I was excited to be like,
you're a real life orthopedic bro scientist. That's amazing. There's not a lot of you. That's amazing. It's just that's why people who look good, who know what, like Huberman, right?
Right.
Or Atia. Yes. I use these guys as like, these guys are, I saw them talk, but they're brilliant. And then you see what they look like. And you're like, you should listen to that guy.
Yeah.
Because he knows and he does it. And it's knowledge in motion.
Yes.
It's like it's bodybuilders.
Yeah.
They're the bro science.
Yeah.
But now with today's world, we have bro scientists, orthopedic surgeons, you know, it's like, and you've been like this for a long time because you were with the bros, but the bros didn't have the internet. And now with the internet, we can all talk to each other and we can be friends, and the nerds can be, you know, buff guys
I'm having discussions with people all across the globe now, people from Japan who help me. Like, it's interesting.
Why not? Why shouldn't everybody be healthy and look good? There's no reason. Everybody will have less problems. We'll have less complications. We'll be happier. We'll have better sex. We'll have better friendships. We'll have better communication. We'll hug each other more because there's less to worry about. It's like jiu-jitsu. I learned fighting. And it's like, why do you want to fight anybody? Because we're hugging all the time. We're fighting. You know, it's like you learn how to deal with people, you know, and like lifting weights. You learn how to deal with these weights, you know, it's just like, and yourself. Working out is a battle with yourself because you go to the gym and you're just like, I got to lift this weight up. I think it's the hardest thing to do. I think lifting weights is the hardest fitness thing to do. And you can argue with me on that, but I mean, the weight is just sitting there and you have to go force yourself to move it and then move heavier weights over time. It's crazy.
I make it a habit every single day
That's what you have to
do something hard.
Yeah.
And I do it right when I wake up.
That's cool.
I do it, you know.
What do you do what's your day like? What do you wake up and do? Because you seem like a pretty organized guy.
I do a cold plunge in the morning.
And you do a lot of stuff.
I do cold plunge in the morning.
That's cool. You have one at your house?
Yeah. I do a cold plunge.
How cold?
49 to 53, depending on the...
When it's dark outside?
When it's dark
and it's
outside.
Freezing?
Yeah.
And you just get in there? I can't even walk outside when it's cold. In the morning, I'm like, I'm going to go back in bed.
I listen, but I tell you, I love my warm bed just as much as anybody.
And it makes you love the cold plunge makes you love that warm bed more, doesn't it?
The cold has taught me a lot. Because when I've done cold plunges, it's got to be the right.
So when I do it,
I can't do it every day. It's a form of very,
What does it do for you?
It's a very rapid mindset change. Like
brings you right back to reality and Earth.
I mean,
sometimes I go out in outer space and I fly in the clouds for a while. So then it brings you right back.
It basically helps me put my mind where I want it to.
Yeah, some things I need to be made aware I'm like a mortal human.
Yeah,
you know, because you feel that ice cold. You're like, I might die. Like you feel it's like jujitsu. You're getting choked. You're like, I might die.
I like that feeling.
It's close to like.
I don't know if
extremis.
I like the feeling. I feel good when I'm able to breathe through it, and then everything's fine.
So breathing helps you. Breath work.
Breath work is huge. Breath work is big, and I think.
How did you learn breath work?
Swimming. And visualization, breath work, all this stuff came very like in high. So it helped me get through medical school, helped me get through tests. It helped me get through public speaking, you know, just
hard things are so important and we try to avoid them. And I agree. I think you should do at least one hard thing every day that you don't want to do and make yourself do it.
Because when you do something hard that you don't want to do, then the rest of your day, your threshold for pain, your threshold for being annoyed at your kids or complicated case or whatever it may be, your ability to deal with traffic, you know, all these things, your thermostat essentially gets modified, you know. And I think unless you have control and awareness, we're all going to just go down that path. And so I think for me, that morning cold plunge just puts me in that state of, hey, you know what? I have control over this. Even as nasty as this is this moment, I'm okay, right? And it's only 2 or 3 minutes I'm in there, 3 minutes I'm in there, you know, but then that carries me for my day.
Do you do it for health benefits? Like mental benefits carries you?
I think,
what about health benefits?
I think
those have been studied.
I think the mental is probably more than I mean, I've heard all the stuff on cold plunge, and I do infrared sauna, I do contrast therapy. I think the mental for me is probably more, but I, you know, like all my pains and aches, I think they're less because of the
sure. So it sets your mental state for the whole day then. Yeah. What do you do after that?
Go to work.
Yeah, just get going. So yeah, some people go surfing in the morning. I know some of my colleagues surf.
On my days off, I'm training. You know, I'm training or
what kind of training? Weight training.
I do a combination of weights, but the biggest kind of thing that's been a game changer in my life for training has been hot yoga.
Oh, that's cool. How long do you do? 90 minute sessions?
And that's another one that I'm just like,
yoga's hard because yoga's
yoga. It's one thing. Yoga, I'm already like flexibility is a problem, but it used to, you know, but
I sweat too much in a hot yoga
No,
class.
dude, you haven't sweat. I'm like dumping.
We're the same then.
No, but
we'll be at pools next to each other. It'll communicate.
But I think so. That to me has been a life.
Have you ever been in a hot yoga class that they have to turn the heat down because you're sweating too much?
No.
Nah. But I've thought I'm like, somebody's going to turn this heat down. They got to turn it down. I'm sweating too much.
No, but I think these things are mentally and physically, they prime you to get through what we get through.
It helps your aerobics or your aerobic
conditioning, cardiovascular fitness. For sure.
The place I first trained, my professor would turn the gym up heat to 90, and we would train for 2 hours. You know, and it was like that every time. So we would just be pouring sweat. And then when you'd go, to a competition and it's like nice outside and it's nice and cool, you don't get tired.
Yeah.
You know. And then I trained at a different place where it was nice and cool and easy, and you could see I could feel a difference.
Definitely.
You could totally feel a difference.
Yeah.
What kind of studies do you think we need to do next? Because I'm really interested. I can put studies together at my institution, and
yes.
I think these things need to be studied. But what do you think is next for this that can get us to the next step of understanding it better, but then implementation and knowing what type of patients and like what type of patients this would be best for? Because everybody is in their own echo chamber, even as surgeons, like trauma surgeons talk to trauma surgeons, and there's very little interdisciplinary discussions. I spoke with a plastic surgeon. He blew my mind about soft tissue and about the importance of these types of, input into our body. So what do you think is going to be next to change minds, basically of surgeons? Because patients are going to listen to us. We need to have surgeons understand this.
So I'll tell you where we've been focusing.
And doctors in general. This is stuff that should be published in big medical journals like JAMA.
Absolutely. So I think from the orthopedic world, there's a lot of good literature there already. Okay. But where we're focusing next is where I think we're going to see the biggest delta is going to be in hip fractures. Okay. And doing the combination of the carbohydrate loading so these patients don't go into surgery fasted. What we're doing now is before surgery, what we're proposing is combining amino acids and carbohydrates before surgery. So we started that protocol at NYU. And so, what do your patients get after they leave the operating room? Crackers and apple juice.
Yeah, always.
Okay. So, but like, why not take advantage of what
There's not a lot of nutrition in that. It's just simple
what are the
carbs.
bodybuilders are taking right after they leave the gym? Protein.
The stuff their
Right?
muscles need.
And so we've gone one step further. Protein is great, but what is it about protein? It's the amino acids. Well, which amino acids? At what dose? And so, yes, you asked us earlier about, yes, whole foods, but something like calcium HMB, which is a metabolite of leucine, in order to get the amount of HMB to be effective, you would need to eat something on the order of like 2,000 avocados. It's not practical. In order to get 2 to 3 grams of creatine, you would have to eat so much steak that it's not possible. And if you're plant-based, that doesn't even exist. So now that's why we made XR to be plant-based, but we put creatine in there. We put leucine in there, right? We put all these different variables in there. So essentially you're getting exactly what you need at that period of time where your body really needs it. So do you need to be on the stuff every day? You don't have to, but I think in order to mitigate some of the complications that we see around surgery, those 2 weeks after surgery and priming them for a week before, that's our current protocol. 1 week before, 2 weeks after. That's, I think, the minimum to really have a meaningful impact. Now we're doing studies with joint arthroplasty with total knees to look at how this will do a little bit longer for up to 6 weeks. The other place that I'm also interested in is ACLs. One of the things that we're starting to see with ACLs, we're starting to see faster ligament incorporation, the ligamentization process on MRI on these post-ops with some of the patients that are in our pilot studies. We're seeing faster ligamentization process. And if you think about it, all these studies that were previously done on reconstructive surgeries and burn patients, where they showed these patients who were given supplementation, maybe your plastic surgery friend who's using this, they're seeing better wound healing. That's soft tissue. Where an ACL, rotator cuff tendon, when I saw that, I'm like, this is the same thing. Physiology is physiology.
Type 1 collagen.
Right?
Yeah.
Right. And so, for example, one of the amino acids that we use is arginine. And when you take it with citrulline, arginine and citrulline together are synergistic. Actually, citrulline is even better because it doesn't get metabolized.
Where does citrulline come from? Is that an amino acid?
Citrulline is a synergistic to arginine. Citrulline is in foods. You can get it like in foods like watermelon. Okay, it's a vasodilator. Why is a vasodilator helpful? Because it helps with wound healing. That's why we do things like PRP. We try to bring blood in.
Yeah, bring blood in. Exactly. Bring this stuff in for healing.
So here's where there's a commonality exists. So if you look on the market for what supplementation are used for, arginine and citrulline are being used for angina, cardiac conditions, erectile dysfunction. Why? Because you're increasing blood flow.
Vasodilators, because you want to get it hard.
The pump that you get at the gym, a lot of it's a citrulline. It's a vasodilator, right? So when you so
it causes a local vasodilation response.
Systemic. Systemic. So that's why.
But it can hone in on those areas that need it.
Well, when your body is healing, we talk about, now let's jump deep into like enthesis and Sharpie's fibers.
The tissue insertion into the bone where the muscle attaches.
Where the tendon and bone come together.
Yeah.
One of the major reasons rotator cuff tears don't heal right is because whenever it heals, it's actually scar tissue.
Right.
Why is that a problem? When you look at the healing process, inflammation, proliferation, remodeling, that whole cascade doesn't just happen once. It happens over a period of time. And you need these nutrients with these vasodilators. Why? Because they bring in blood flow to clean out debris so then you can lay down much better
That's why
tissue.
this works.
Yeah, that's right. Yeah.
Because what I realize is like it backs up. and then you got to get that stuff out of there.
That's right.
So you got to get the good stuff in, and then you got to get the bad stuff out. This is just one part of the whole process.
That's why when you ask me what is the one thing, I don't think there's just one thing.
There's not one thing. It's all the stuff. You got to do all the things.
So when you and I have only 20 minutes to talk to our patients about surgery, and we're talking about
we've been talking
else,
for hours.
You know, but I'm just saying when you're in front of a patient,
and I'm barely understanding this.
Right? when you and I are in front of a patient,
let me just fix my camera.
When in front of a patient, to have a meaningful conversation with them, that's going to make an impact. And you still got to talk about what's the difference between an anatomic and a reverse, or this and that, or am I going to put a collagen patch on your rotator cuff?
It's too much. It's like people can remember in groups. It's called chunking, groups of threes. That's why phone numbers are 3 numbers and then 4 numbers, because we can't remember 7 numbers. And so the way our memory works is it's got to be like maybe like 2 or 3 things. You know, like 2 things pretty easy, and like 1 thing you forget. But if it's 3 things, that's like the secret. And so the way I would remember things is like I would take a lot of complex stuff, like all these numbers, and I try to just make like one little bubble. That's why like all those things I wrote over there, I made these bubbles because they're these complex topics, but I could like, there's only like 4 or 5 things up there, you know, or like 5 or 6 things. But like, so then you can separate, you say, oh, 3 over here and then 3 over here, and then that's half. So like and that's what I teach my kids. It's like how to use your brain to solve problems. And like, these are tools that you just either figure out on your own or somebody can help you with. And then if you have the tools, you can solve a lot of problems with that.
I completely agree. And that's why.
So you got to keep it simple.
So the other thing we
use simple words, say like 3, okay, you know, reinforce, you tell them, and then you tell them again. And then at the last you say, okay, these are the things we're going to do. See you later. Yeah. Right. But then it's the last thing that you say, but it's like in these basic segments. It can't just be, you know, we're doing all this complicated biochem. You know, I talk to my patients like that. I tell them, but it's like right in the middle a little bit. And then I kind of just like, these are the things you got to simplify it.
So I agree with you 100%. That's where for patient compliance. So if you have surgery and you get on the XR program, you put in your surgical date, and that surgical date then triggers a patient journey online and text messages. So the patient will get, and we have about a dozen different surgeries, whether it's a reverse or anatomic or ACL or knee arthroplasty, hip arthroplasty. We have patient education journeys. So, hey, Mike, your rotator cuff surgery is coming up in 3 weeks. Remember to do your isometric exercises. Remember to eat your protein or your nutrition based on your dietary plan. Remember the night before surgery, then we'll have another email, take your carbohydrates. So,
I had to look it up too, you know, so to have all that stuff there, it's like, what are the specific instructions? I take the white one at this time.
Yeah.
So
like we have a journey.
You can just follow that. The timeline you guys provide was really nice too.
So all these different resources are just going to want to make compliance happen, right? Because patient compliance are already nervous. And this is what we talked about, you know, you don't want to overwhelm them. You want to give it to them at chunks, and you want to. But if someone's having surgery that doesn't know about this stuff, they welcome this, right? They welcome this. They want
to do all the things. They want to know, and then they can decide if they want to do it or not. But at least then they know. But a lot of people want to do everything they can.
So I think at the end of the day, to kind of talk about what is it that is going to take orthopedic surgeons to, you know, have awareness on this, it's going to be education, more research, and then them also experiencing this for their own. Like, to me, I've seen the difference when my patients are optimized, or when I say no to someone, optimize them versus someone who I just operated on and then they had a complication.
It's what we do, and we see by treating, and
this is why it's called practice.
Exactly,
you know?
and it takes time to get to that point.
Yeah, and because I also sit in a position of I'm doing a lot of redos, I have the opportunity to kind of look back and say, you know what? No wonder you didn't heal. They checked, you know, your primary checks your vitamin D, but your orthopedic surgeon never really talked about it. You were low. So then I go back and I say, hey, look, I'm not going to redo your rotator cuff until your vitamin E gets better, right? Sure. I'm not going to do your rotator cuff until your albumin is better, right? I mean, that's the problem, right? We try to get surgery as soon as possible, but I think we're actually doing a disservice to ourselves and our patients.
And I think once we have more awareness about this and we're checking into where the deficiencies are, we'll know when it's critical for those people to actually make that step. And then we can advise them, hey, your numbers actually are low. You should do this.
I will not.
It's like having surgery. It's like, we can do surgery or you should do surgery, right? I mean, sometimes there's cases where you should do surgery. Otherwise, your leg's going to be crooked. Our shoulder's not going to work. You should take this nutrition supplementation because you're at this potentially deficient state. That's where AI can help us. That's where the machine learning can maybe help us and give us some better understanding of these things and what we should be recommending for our patients based on their factors that they come in through the door with.
This is why I would love to see more surgeons thinking about this metabolic report card. And this is what we're talking about is, you know, it's hard to do these studies if no one's checking them to begin with?
Exactly.
Right. So if we have more data,
it's like doing a meta-analysis. There's no studies out there to write a big meta-analysis on. We can't write a meta-analysis on these things yet, on these specific algorithms in terms of what the interventional modalities are to say this one's better than the other one, because I think that's the next thing that we're going to get to. Which one's better? Because it doesn't end here, right?
No,
it doesn't
not
end
at all.
with XR.
Can you go back to that? Can you go back? I just want to show you one thing that I think.
Because I wanted to talk to you a little bit about your protocols and about whether or not you think this is something that will be either expanded, like these protocols will be then expanded, or there'll be totally different types of protocols that are more specific for certain cases. What do you think about that?
I think we're definitely evolving. I think we're definitely evolving in kind of where we're going. You know, kind of where we stand right now with the protocols is really coming in about what you asked before, is when is the most critical time?
Yes, exactly.
You know? And so, we started out with kind of saying, we know that whole food and nutrition can decrease complications, but then we realized it's very difficult to have people eat these kind of foods in a short period of time. And then that was the 2020 Rana Award that said, hey, you know what? We can get better with our complication rates by just providing those key amino acids. And this is a paper we wrote more recently kind of saying, hey, we really dialed this and get much more refined, right? We're getting much more granular in how we're doing this. And there's a lot of literature just showing what you put into your body, even for rotator cuff, that these patients who had a higher protein intake with these amino acids actually had a faster, rapid recovery. So these studies are coming out, right? And these are more recent, but this is got to get into our residency and our educational kind of literature. This is the HSS paper that kind of showed amino acid supplementation with muscle loss. And look what's been happening the last few years. It's just going up. And so we still need to do more studies, but these are the systematic reviews that you're talking about. This is just RCTs just on amino acids.
So there are several more. It's building literature.
So look, these are all the studies that have been done only on amino acids. And guess what? These are all on healthy patients. If you look, Japan, Italy, and a few from the US and one from France.
There's a lot of stuff out there.
There's a lot of stuff out there.
So we have mostly total knees, ACL, 1 on hip, 3 on hip fracture. I see total knee, total hip. So mostly arthroplasty.
Arthroplasty.
And in those cases, you have time. You know, it's like you want to get these people optimized. We're going to check nutrition. They're typically a little older. You know, so I see a lot of shoulder patients that are going to follow that same.
Yeah. So the arthroplasty
profile.
elective cases are a great opportunity. I mean, do you have a cutoff for your A1C before you're?
Yeah, I mean, definitely 8. 8's the major cutoff.
So what do you do?
It should be below 7, but some people can't get
right?
below 7. Oh yeah, definitely.
Okay, so the same thing.
The complications are higher.
So I'm just saying, expand your criteria. Be more selective. That's all I'm saying. You'll still get to them, and probably if they're not optimized, that's a complication waiting to happen. If they're going to go to someone else, then fine.
Yeah.
You know, I don't need to do every single case. I'm very selective now with who I want to help. Right. And, you know, I think that's one thing I've refined in my practice.
Because if they get a complication, it's hard to argue that you're helping. You know, it's like we're having a problem here. And once you get better, we got to get you through this complication. It's just a lot. It's a lot to go through for both of us.
Yeah. So you know, this was
nobody wants it.
This was the Hans Reich study that did muscle biopsies before for a week, and then they showed the satellite cells increased before surgery.
Yeah.
And these are the patients that went on to have, you know, less atrophy and better outcomes, and then the same follow-up. So this was another paper, same thing, 1 week before, 2 weeks after. And then this was the kind of showing early on you have a difference, but then 2 years later, there was a significant difference 2 years later. So the group that was supplemented that came out of the gate better, even 2 years later, was reflective of how they were going to do. So you asked, you know, what's our protocol? You know, we see this in hip fractures and trauma. This was the 2 weeks after. A lot of significant cost savings. And we're behind the 8 ball, by the way. They've been doing it in plastics a long time. The other place that I think this is going to start to maybe be interesting is, you know, we're putting patches in rotator cuff tears, right? But in some of these studies, we're showing that you can actually provide these amino acids to have higher collagen deposition on the actual graft.
And I was going to ask you about that. Is there any local application for these, or is it all systemic? So it's oral and then it has to be absorbed, and then it's going to be within these specific body locations, or is there any topical uses?
So this is kind of metabolic. So it's something that it gets consumed.
Right, but we inject PRP back in the shoulder, right? Would we ever think about injecting essential amino acids in the scaffold or something like that?
I think,
or is that crazy?
Through nutrition,
because people do peptides.
You can do peptides, but so peptides are a little bit different. Peptides get broken down
It's a signaling molecule.
It's a signaling molecule, but it gets broken down in the gut, so that has to get injected systemically. So insulin,
it gets injected just to get into the systemic
into
system,
the
right?
system, into the system.
Okay.
Yeah. So it's systemic. So whether you're talking about insulin is a peptide, right? These other peptides that they're talking about, that's not technically legal, but like BPC 157 and some of these other peptides, those are peptides that you can inject and you have a systemic response.
Do those have any clinical 157? Is that any clinical use? Because I don't use that. People ask me about it. I say I don't even know what that is.
So BPC 157 is got a lot of animal studies on it.
Well,
okay.
Is that something in clinical medicine we can use? Do you use it?
I don't prescribe it. We can't prescribe it in California.
Oh.
But there are a lot of my patients who are taking it, and there are some people outside of California who can prescribe it.
Do you know what it's supposed to? The effects are supposed to be?
Oh, absolutely, yeah. So I just actually did another podcast on BPC 157. So
is it effective?
Yes. The studies are on animal studies. And that's where. So the reason it's not legal yet, and I don't know if it'll ever be, is BPC 157, which is the more common one that people talk about. It stands for body protein compound. It's in your gut. It's a protein that's in your gut that helps with regeneration of your oral mucosa from your mouth all the way down to your butt. So your gut needs to keep everything out from your inside. So it's essentially the outer world. So that regenerative ability for those tissues to constantly reconstitute is a higher demand, right? And so BPC 157 initially was identified in gastric mucosa.
Is there's more turnover in the gut because it has to get things through and
all day. You constantly
a lot of metabolic activity,
right? And the regeneration of those tissues is highly dependent on neovascularization or angiogenesis,
because they shed and they have to bring new cells in.
That's right.
It has to vascularize.
That's right. And so a lot of these rat studies that were done with BPC 157, Achilles tendon that were ruptured, that were cut, they healed much faster, tremendously faster. So the good news is they work by increasing angiogenesis and neovascularization for what's the big problem with our meniscus tears or ACLs or tendon problems is blood supply. So if you can enhance the blood supply, then you're going to have better healing. Mm-hmm. The problem is if you have someone who you don't know has cancer and you provide this to them,
you're ramping everything up.
You're ramping everything up. So that's why it works
too good.
It can be a problem, right? It can be. The other question is, well, let's say you're having rotator cuff surgery and you're only on it for 6 weeks. So that's is that
a bad thing?
So that's a very,
or would that be helpful theoretically?
So
would you? It does opinion.
That comes up. So my opinion. Okay, my opinion is, so I make it very blanket disclosure to my patients. I say, look, I can't prescribe it, but I also,
if I could, it'd be really cool.
But
would you say that? It's like if it works, it would be really cool.
Well,
if we could have access to it and use it.
Well,
in certain cases.
I kind of.
Or is it maybe too dangerous?
No, I don't. I can't comment if it's too dangerous, but I can tell you, in my practice, I have a lot of patients who go to the regenerative medicine guy next door.
I've heard it too.
They got next door.
Yeah, they get it.
And they get it. So to me, it's like when the conversation comes up about steroids or growth hormone or stuff, as opposed to me being like, I don't know what you're talking about. I'm not going to talk to you about it because I'm not going to talk to you about it.
I want to talk about it.
I go the other way. Yeah. I lean in.
I do too.
Because I want to know, okay, what are you taking?
Yeah.
How is this harmful? How is it helpful? And then so I'd lean into it.
But you know a lot about that. You can communicate with them.
Well, because I'm interested in it.
I don't even know how to talk to them about. I've had people ask me about 157 and I've looked it up and I don't know how to advise them on it. And it seems like something that I should pretty much tell them not to do. I think, especially if it's illegal. But I think this is something that people were telling me they were injecting into.
They're injecting, They're injecting, and some people are actually trying to inject it into the area, which is not necessarily what you should be doing. Look, at this point, the first thing I'm going to say is it's not available in the market. Yeah. It's off label, or you shouldn't be using it. And the people that are getting it, they're you can get it online right now, right? You can get it online, and the cost is not that high, but patients they're being sold as like non-human use, but people are taking it, and my patients who are taking it, I don't know if it's that or whatever else they're doing, they're recovering better. They're recovering better. So, what I tell them if say, hey, I'm going to do this, how long should I do it for? I say, look, you may only want to do it for the time that your body is really at risk. So for rotator cuff tears, we see the majority of re-tears in the first 3 months. So I tell them, you may want to just stay on it for 3 months and then come off after that.
So we saw some uses in cancer. We saw some uses in international consensus regarding infection. Where do you think this goes next? Where do you think the nutrition debate goes? Is it going to be?
I'll tell you where I think.
Do you think there's a factor that we haven't figured out, or do you think it's a balance and timing of what we already know is important in terms of like how these things are working? It seems to me that this is it's like we can see all the players and we can see that there's a game going on, but we're not sure like who the players are. Like we're not sure like what the players are like back at home and what their lives are like, and like whether or not they're going to play baseball next year or play football next year. Like we just know there's some kind of game going on over there and like something's happening and there's an interaction happening, but we don't really know like the real details of that process over time, how it changes and all the different circumstances of how the levels are relevant at different times. Like, so, what do you think is going to take to like get to a better understanding of this?
I think, when it comes for us to have a successful outcome as orthopedic surgeons, there's some variables. I think the implant side is pretty much done. I think we hit a ceiling on
like
which
small
anchor
changes. Yeah.
Right.
Yeah.
I think
hip replacements are lasting 30 years. They don't get wear.
I think, the neck shaft angle of your reverse, or whatever, the offset, I think we're now just minor. Okay. But I think we're, where we're going to see, particularly with, in regards to nutrition, I think it's going to be an adjunct to orthobiologics. And I think orthobiologics is at its infancy. I think there's it's overrated in certain applications. It's kind of misused in certain applications. This whole thing, stem cells, I think we have to be very careful about. But I do think the biology of healing is where our next gap is going to be. And this is where I think there's not going to be one thing as much as it's going to be this holistic approach where if I'm doing your rotator cuff, and this is what I'm starting to do now, by the way. Okay. So I've been starting to use BMAC, bone marrow aspirate. I wanted
to ask you about BMAC. I'm glad you brought it up.
Yeah.
Bone marrow aspirate concentrate.
Yeah.
So you are using BMAC.
Yeah.
Okay.
I've been collecting some cases and it's been anecdotally, it's been helpful.
The studies say it should work.
Yeah. And so
do you use it for revisions or for primaries or when?
I use it mostly for revisions. I
can't get it approved. By the insurance won't approve it.
I think
I haven't submitted.
Depends on the system you're in. Sometimes,
and maybe it's a systems thing that I need to look at.
Maybe it's a system.
I think it costs a lot of money.
I think it can cost a lot of money. You can charge different ways for it.
Oh, maybe there's something that I can look into for that then. Because if there's just not that many studies out.
There's one study by Dr. Hernigue out of France. Mm-hmm. Okay, and so
rotator cuff, right?
Rotator cuff, and he's got 10-year follow up, on that. And
we just reviewed that in our journal club yesterday.
Did you?
Yeah.
The Hernigue paper.
Yeah.
10-year follow up. So I've done lectures with Dr. Hernigue. He's the man. And, I'm going to be seeing him again another. So I've learned a lot from him.
It got me thinking about it, looking at going back in for a revision. I've always been taught use graft. If you're going for a revision, you should consider graft. I think that's a good, because we were thinking about graft because you hear primaries and grafts for rotator cuff repair. Should you use it? Do you augment? But for a revision, even if you can repair it, I think augmenting it, you can make a case to use graft.
And where you
can also make a case not to use graft.
Where are you putting the graft?
Over the tendon. Some people put it under the tendon.
So I'm questioning if that's the right place.
Well, and so there's different technologies that are being worked out for maybe, graft being under above, like sandwiched, right?
Yeah.
So, and like how you get it in and how you get it structurally sound. I think getting graft in can structurally help, right? Yeah. And so then there's the structural component, which is on the tension side, which is where most of the force is going to come from in terms of like preventing failure. And so on the tension side, where how it fails, that's going to be the most mechanically stable point. But if you can have additional mechanical stability below that, what I worry about, what other people may worry about too, is the biology of that graft host interface of getting like too much tissue and then getting vascularization through that stuff. Because collagen's good, but maybe too much collagen in the wrong place is not good.
I totally agree. And I use a lot of grafts in my practice, a lot. And mostly
like dead stuff.
Yeah, mostly in the knee. You know, I do a lot of
Decellularized
I do a lot of
collagen.
well, I'm seeing also in the knee. I do a lot of multi-legs, right?
Yeah,
Where we're doing
you use allograft.
there's a lot of allograft, right? And so, you know, like these some of these like patella tendon revisions that we do, I'm not using the huge chunk of Achilles tendon allograft. You know, sometimes, you know, the distal biceps that we do revisions, right? I don't think it's a good idea to bring a big chunk of Achilles dead tissue in there. You just need just enough to mend in.
Yeah, at the right spots, right? For those load sharing benefits and mechanical stability.
And that load sharing and the mechanical stability is only short term. Ideally, which is you need is the biological healing, right?
It takes over.
So,
which is cool.
Which is very
that's
cool.
really cool.
So I think where I'm excited
about, it can get better over time. You're like, I did this and now it's getting better and I'm not even doing anything, but you're getting better. That's cool.
Yeah.
Your body's doing that.
Yeah. So I think where I think medicine is going is a holistic approach of saying, okay, let's look at your bone density. Let's look at your metabolic factors. Let's look at your nutritional status. Let's bring in the nutrients that your body needs at the time of healing. Let's take tissue that is deficient. So for example, let's take some bone marrow if we can from another part of your body.
You harvest it from the iliac crest.
It's you know, you can get it from anywhere, but the best place to get it from is the iliac crest. You know, do
you take it local if you're doing shoulder?
I used to,
because I've heard people say that you can just get it right there. And
I used to, but it's significantly inferior. So if you look, so the study's been done now. If you look at the concentration of your mesenchymal stem cells at the tuberosity versus femur, they are substantially lower than the iliac crest. So think about it. If you look at those osteoporotic bones in these rotator cuff tears, they're cystic, they're poor quality tissue. That's a very important part of the equation. So if you're just thinking about the tendon and the sutures in the tendon, whichever configuration you want to put on, and yes, I do agree, if it's very deficient, you may want to add your biological patch of choice, okay, on there. Whether it goes on top or under it, it's another conversation. But augmenting the tendon side, I think, is important. But I think the bone side and the enthesis, where this comes together, is actually also been overlooked. So for me, I'm looking at all of this. And so in these revision cases where I know I probably got one last shot before this lady needs to go into a reverse shoulder arthroplasty, something much, much more of a big deal, some kind of big tendon transfer.
Can't go back.
So that's where I'm doing the iliac crest. I'm bringing in the amino acids.
Give her the best chance
So I think
to heal.
this is where it's at with orthobiologic augmentation, because a lot of these pathways are basically shared pathways, right? And so there's a lot of good literature now showing if you're augmenting one pathway, there's synergistic with the other. And I think that's essentially where we're going to try to get at, is look at the patient's metabolic status. And I think the stem cell is getting a bad rap. It's almost, we've kind of ruined the stem cells because it's been abused. But I do think it's
almost like PRP. It's like it almost gets a bad rap. But
I think PRP and all of this has been misunderstood.
Yeah. I think people wonder if it's like, why doesn't it work? It's like, well, if you study it for, something that it wouldn't work for, it's like if your arthritis is severe and you're testing that, it shouldn't work for that.
Also the dosing. I mean, this is the same. So if you go to the
quality of what you're getting.
Yes. If you go to these orthobiologic conferences that I'm involved in now, I've learned so much about like the dosing, and all these systems are very different. Whether, your platelet count is very important in your outcomes. So when these outcomes are becoming conclusive, if you look at the dosing, they were underdosed. And that was the problem I had initially when people were going to buy these supplements. I was like, yeah, you just bought a sprinkle of HMB or glutamine, and that's why it's
not enough stimulus.
You got to hit the stimulus. So I think this is where it's going. And I think the biggest jump is going to be probably when we learn how to navigate these mesenchymal stem cells, because right now we can get them, we can harvest them, right? It's autologous, right?
And then what happens? They just go there. And
just go there, right? Yeah. They just go there. And I think that's where we still, and there's a company called CRISPR where now they're working on
gene sequencing and production. They produce like proteins from the gene sequencing,
and they're able to, and you're able to now direct these mesenchymal stem cells depending on where they are in their lineage.
I want this, and then I want this type of stem cell and this marker.
It's like having the fastest Lamborghini, but doesn't have a roadmap. It just doesn't know where to go, right? So you may have the potential, but unless it's directed And there's a lot of good literature now also showing that, yes, you can have the mesenchymal stem cells, but by the environment that they're cultured in. So this is what the studies that we're doing now with Dr. Mazak. We're talking about looking at the stem cell proliferation. And, there's different places where you can get these proliferative tissues from the mesenchymal stem cells. Platelets we talk about, but bone marrow is really good. But Dr. Mazak has also been showing from the bursa. So
yeah,
the
right.
bursa. So
he was kind of advocating for not doing too much of a bursectomy, especially around that time of where the repair is. He was saying that the stem cells not the critical, but the highest number of stem cells were found right near in the bursal tissue, right near where the tear was.
So
that's right where we just shave all that stuff out usually.
So just take a step back and think about what we're trying to do.
It's like, how long have we been doing that? Now he's just now telling us you guys are taking away all the healing cells.
So
people argue about it, but still, it's like he studied it.
So his literature is very strong.
Very strong.
And he's actually shown the proliferative potential of the mesenchymal stem cell.
Yes, I think he presented his data last
year. So this is what him and I are talking about is the proliferative ability of those mesenchymal stem cells is actually better than even the bone marrow. It was a head-to-head study. So think about this.
It's so interesting. Your body, now that you stimulate that in my brain, but those cells are right there, and they want to heal. They are trying to heal, but the muscle of the rotator cuff just keeps going, come over here. It's like Scorpion, just pulling them back, and they can't get there because they'll never reattach. But the surgeon is the one that reattaches it.
So for a second, forget about our need as a shoulder arthroscopist to see, right? And go back 1,000 years and you cut yourself, right? Your body heals by bringing in platelets and the scar, and you heal.
Yeah, it's
right?
PRP. It's been around for
right.
ever.
So you're healing,
goes
right?
There. That's what it does. Your body does it.
So then when you have that kind of realization that the body's pretty clever, way clever than we are, we're just trying to biohack it or whatever, right? But when you have a torn tendon, the bursal, like that infiltrative process, is probably your body's attempt to bring in tissue and cells for healing.
Yeah.
But we just go there as orthopods and we're like, I can't see.
Get this bursa out of the way.
So get this bursa out of there.
Yeah, bursa is cool. Bursa is interesting. Bursa regenerates. It's like the electron on bursa comes back, and the bursa and the rotator cuff comes back under the subacromial space. You can always see it there.
So I think
tissue.
So
it wasn't there.
So Dr. Mazaka and I have been really
tissue.
geeking out on this because I really like where he's going with this local tissue that was probably there, for a purpose. We can harvest that, okay, and then concentrate that, So he's got something called the.
Maybe you can grow rotator cuff by sampling bursal tissue.
Well, what he's doing now is, he's taking bursal cells, and you can actually physically chop it up to help release some of that.
But his studies showed like what's in that stuff, right? Like he showed like what's their stem cells in there,
there's MSCs
where
in there.
they are, how much they are,
there's
and like
MSCs
what
in there,
locations.
and they can go on to become bone, collagen. Yeah. So this is exactly the conversation we're having.
Actual stem cells, you already have them.
So now
I'll just tell patients when they say, "Can I get stem cells?" I say, "You already have them." Yeah. Did you tear your rotator cuff? They're trying really hard.
That's right. So, but here's the exciting part: you can feed stem cells. And let me just show this. This is where I think we're here. Here. So,
go ahead.
So this is where branched chain amino acids can actually improve stem cell proliferation. This is huge. Okay. You can use amino acids. There are patterns that we're finding out that specific. So you're asking, where's the formulation? Why do you have this? It's based on the patterns of amino acid metabolism that your body requires for human mesenchymal stem cells. And you can use these to really influence which direction you want them to go.
So the MSCs get activated by branched chain amino acids?
It fuels their metabolism.
But is there a direct effect on stem cells?
Yes. So these are the studies that are showing that, for example, glutamine, that's
an excitatory neurotransmitter as well. Like it's an amino acid, but it's also a neurotransmitter. So
glutamine has different.
And you can get in your diet.
You can get in your diet, but the practicality of getting amount of glutamine in your diet is almost impossible to get that much.
Is glutamine essential or non-essential?
It's glutamine is a conditionally essential amino acids, which means your body can typically make it, but it becomes conditionally essential. Which condition? Trauma, stress, burn, fracture.
And you don't have it,
which means your body can't keep up.
And then you really need it.
So that's why it's a conditionally essential amino acid. All right. So it becomes essentially essential in those settings. So this is where, by reverse engineering what we want, right, you can then create a formulation to say, hey, look, let's say your mom's got her secret, recipe. She puts this much of this and this much of that.
She makes good tacos.
Right. And so this is kind of the same way, saying, hey, look, what do we want as orthopedic surgeons? What's the science behind what gets tissues to heal? Let's think about really granular about, okay, not just protein, but like, what is it specifically? And once you got that, then we got to find a way to implement it in a package that makes sense. So I think this is where we're at. I think this is where the next studies are.
Do you think there needs to be more? Do you think there needs to be more focus on stem cells? Do you think there needs to be more focus on biologics, or do you think there needs to be more focus on nutrition? Do you think those things are, obviously they're related, but do you think the studies or the research funding should really, because it's got to go somewhere? Because I think it sounds like we kind of got a handle on things with nutrition to a certain extent. If you just look at, okay, well, these are the things you need, but we can look at the details. I don't know how important those things are. Like, do you think those things are going to be as critical as the debate on stem cells and other types of biological treatments, like advancing nutrition understanding?
I think the potential of being able to implement, whether you want to call it stem cells or cell-based engineering, right?
Yeah.
I think that's where it's at, and I think understanding the genetic programming and being able to tap into that is going to be really where it's at, where we can genetically kind of create more efficient pathways. And I think the metabolism of those pathways should not be overlooked. So you can provide, so this is exactly what we're talking about. So I don't think they're in silos. I think they're in the same.
They interact.
So yes, this is the study that we're going to be doing now. Mm-hmm. We're going to be taking patients who are supplemented before orthobiologic procedures. And let's say Miss Jones is going to come now and she's going to have her PRP done. Well, why don't we see what her PRP or her mesenchymal stem cells are going to look like when she's supplemented? So what's the whole concept behind, this stem cell, right?
Are they upregulated? Are they having an interaction? Exactly.
That's right.
That was my question.
So we're basically taking some bone marrow aspirate, we're concentrating it, or we're taking blood and we're just removing the platelets because it has those key factors. And then we're taking those key factors and now we're putting them in an area that we want healing. But what that still needs, it still needs some metabolic nourishment in order for that activity to happen. And there's a lot of good science already showing that the environment in which these stem cells are is very important in how well they're doing and how they'll differentiate. So I think they're all kind of interrelated. And so this is where, I'm going to have my kind of angle on maybe the metabolic side.
Yeah.
And then, but there's going to be some really much more smarter people looking at the genetic side.
Sure. Genetics. And then I talked, like my plastic surgery buddy I had on last, he was talking about it's a volume issue. He was saying the amount of healing you get with stem cells, he uses a lot of fat grafting, is really based on volume. It's how much can I put in? If I have a space
Correct.
that's supposed to take a certain amount of cells and I can only put in half as much, those cells are not going to have neighbors. And if you don't have a neighbor, they have nobody to talk to and then they end up dying. So it has to be a whole system of cells. So if you can actually fill the volume and then you get them talking to each other the right way with the right factors.
That's right.
And then you pray and you hope and the magic still happens,
That's right.
right? But these are all the things we have to try to understand is like, it's not just one, it's not even just one realm of understanding. It's like a whole different realm of understanding like volume and how those factors can affect, the scaffold structure of them communicating with each other. It's these scaffolds that are important. You can't build a house without a foundation.
That's right.
There's nothing to build off of.
Yeah. So I think we're at a super exciting time.
It's very exciting.
I'm still like, I love being an orthopedic surgeon for all these different reasons.
Super cool.
It
gets cooler. It's been getting cooler. It's been getting cooler because the more I've been learning, the more I've been reading, the more people I talk to that are brilliant, that've been studying this in these parallel ways as I have,
Yeah.
and just as obsessed like as I am with things in a different way, because I had my own obsessions through shoulder surgery,
Yeah.
and, getting through a fellowship in that, and then having, and then meeting and like having really similar interests in helping people and pushing the boundaries of what we've been taught. And I think we're at a really exciting time right now with these podcasts coming out, being able to get on shows like this and just have a really detailed, deep discussion about things that we think matter, and how we can make those things better, because I'm going to keep doing my thing. You're going to keep doing your thing, but we can just keep doing that, or we can try to continue that and improve on things and try to solve the problems that other people just say, I don't know, whatever. What
You
do
have
think?
to think outside the box.
You got to think outside the box. And you got to keep that pressure.
Push forward.
You got to keep the pressure on.
And I think also like one of the things that kills me is feeling stagnant, right? And so I think, being curious, being wanting to push the performance of our patients' outcomes and how we do things, being very efficient in how we take care of things. This all kind of, you have to have that personality to be able to kind of keep pushing forward, and we're in a great time. And the reality is, we're surrounded by really smart people that, can help.
It's like every day I go into work, I'm surrounded by brilliant people. It's like, I feel very fortunate.
Yeah, absolutely. This whole thing was built on, a lot of mentorship, a lot of like me learning from other people, and that's going to continue. I think, we should never stop learning. And I think we're kind of at the infancy of all this, and the application part and getting it into practice, that takes time.
Do you have any advice? I know you're going to give some more, you have a lot more lectures to give throughout the years, I'm sure. Do you have any advice for young surgeons listening, young medical students who are interested, young entrepreneurs, or anybody who's interested in, really kind of in progressing themselves and going through the process, either way, going through surgery, going through, training, or, say they're in business, they're interested in nutrition and they want to go to the next step, next phase in their life and kind of push to the next thing. Do you have any advice for, young people listening? And cause, getting to your point, you're more established, I would say, than just, people would be pretty happy at being an orthopedic surgeon. There's a lot of people out there that's something to rest on, but that's not enough for you.
I think one of the most important things is tracking yourself. I think something as collecting your patient's data, I still, even now, I think about my cases, and I take these little notes, and I'll still refine every single step, and I'll think about it again. So I think the sooner you can track your own progress, things that you're thinking about doing, that gives you a little bit more of a reality check of which direction to go.
You have to be critical of yourself.
Being critical. I think being critical. So regardless of where you go, I think being humble and, being open to learning, I think that's an important just trait to continue to push yourself, and be okay with not knowing and ask questions, and then you just track yourself,
I loved asking the dumb question in medical school. I was that guy. I would just ask, I don't understand. Can you, and I was like, hey, what do you think about this? And it's like, and then it actually, a lot of times it turned out to be a question that a lot of people either didn't know.
They're just shy to ask.
Thanks for asking that question.
Yeah, they were asked to shy to ask,
I just want to know. I just want to know more. So I have a similar mentality. I'm curious.
Yeah. So, I would say, like be humble, track what you're doing. And then, I think relationships are really important. I think relationships are super important. Be
nice to people and like be honest and like keep your friends. Like keep your friends close and like
just don't be an asshole.
Don't be an asshole. I say the same thing. Sometimes I'm an asshole. I try not to be. I try not to.
I can't tell you.
You should try not to. Like some people is like, are you trying not to? Yeah. You should try a little more not to be an asshole.
No, I just think it's reflecting on like, how all this kind of happened.
Because we're surgeons, we're busy,
No, I get it. No, but still, but my point is like, I think when it's like the universe and karma in certain ways, I think so too. Yeah. And I can't tell you the number of things that came up through this whole process of working with XR, for example, and trying to put this together, and it had to do with relationships, really, and I think. I had a conversation with someone 15, 20 years ago. I had, I'll share a story with you without, telling too many names, but, one of the guys that I was going to do research with for one of our studies, they sent it to a big university to see if they can push the study forward. And the fellow was like, I'll run it by my attending to see if they'll do the study. And the attending was like, I don't know about the study, let me take a look at it. And then he saw my name, and then he's like, oh, this is the guy who got me through medical school or residency, where he had a really tough time, which I didn't even remember. Like, it was that bad. He was like really depressed and went through a lot of bad stuff, and I remember he was my junior resident. I was like, dude, don't worry about it. I gave him the knife, got his confidence up, and I didn't think much of it. I was just like, man, you're fine. You're good. Like,
you believed in him.
Yeah. And
you trusted him enough.
And then fast forward 15, 20 years, he's like, dude, you changed my life, man. I will do anything I can to get this thing going, and we'll make it happen. And sure enough, he did, and at that point, I wasn't even thinking about what was going to happen 20 years later, 15, 20 years later. But it was just something like that where I think, just if you do good things, and have good relationships with people, I think that's an important piece, that I think sometimes gets overlooked.
Well, do you still stay involved in the ASES? Are you involved in the sports society? Do you go to both meetings?
Right now it's been a little bit, been spread thin, but yeah, I actually, me getting back into this,
and Academy, I'm sure too.
Me getting back into this, I'm more involved than I was before, lecturing and being involved and learning. I feel like sometimes I'm like in like studying for the MCAT again, because all these things that I'm learning, and they actually don't have anything to do with like necessarily orthopedic surgery per se.
Yeah, right.
Right. So
like day-to-day orthopedics, right?
That part is, obviously, we've gone down. That never ends. There's always complications and things that we have. And, I always
your phone's got to be on, and you got to be ready to pick up the phone and figure it out. All right, well, how are we dealing with this one?
Yeah.
But yeah, I mean, just spreading an awareness about this, I think, is so important. Getting more people just to understand it, just to take a look at it, try it, maybe bring it up to your patients, maybe have some people try it, and then maybe some surgeons, maybe it takes that little step of like, try it out for your patients. Maybe it is a placebo. Maybe it's not a placebo. Maybe a placebo is a component to it. That's what people say, right? And so when these things have been studied, and then you see how the outcomes look, there's things that shake out, and like placebo, not placebo, actual important nutritional things that are having an actual effect here. What do the outcomes look like? That's what's important. The starting block and then the ending block. And it's clear that it's not a placebo. It's clear that
there's so much good, and that's kind of been my thing, is just kind of sharing the message of educating, learning this is a variable, and it doesn't have to necessarily be use XR. It has to be, just don't overlook this aspect of your patient's status, right? Everyone's kind of knows about the hemoglobin A1C, but just take a little further step back and say, hey, there's other metabolic variables that actually play a bigger role in how Ms. Jones is going to do 6 months from now than whichever anchor I put in or which implant I use.
Right.
And I think that alone will play a big role in us preventing a lot of complications and having better outcomes.
Well, good. It's been so awesome having you, man. And I've learned a lot from this. And I feel like I'm going to have all these basic science terms in my head for a while. But this is something that is just becoming more interested in. And it's not something that I think, basic science may have used to be a chore. I think it's something that I think there's more just knowledge on it with just overall health podcasts and different people like Huberman and Tia talking about it. And then now you talking about, I think you're going to be a major voice from the orthopedic community in this. And it's been really great having you. We spent a lot of time talking about this. I'm just so glad you came over. We took the time to really
it was fun, man. I enjoyed
the details
it, man.
out on this one.
Yeah, thanks, man.
All right, man. That's it. So thanks for coming in. I
Awesome.
appreciate it. That's it on the LA Shoulder Podcast. This is the 5th episode, and stay tuned for the next one.